Hi everyone, very warm welcome to all of you guys. Please let me know whether I'm clearly audible and visible, no issues with the audio video. All right. Alright guys, so myself Dr. Vaibhav Jain, and today we will be discussing about some parts of dermatology, and then I will give you the guidance how to go through the examination. Tomorrow is going to be the day, the D-day that you are waiting for, the day that you are preparing for from such a long period of time, right? So this is what we are going to discuss. Dermatology is going to be a quick and crisp revision where I will be focusing on all the important topics that has been asked previously, right? So those things we are going to discuss, and further on we are going to discuss how to give examination or how to approach to the exam and what are the different key points that you should be remembering while giving the exam. This is going to help you out, right? All right, just a moment. All right, I know you guys might be nervous, anxiety is going to be there, but yes, definitely your hard work is definitely going to pay off tomorrow, right? Everything will be sorted. Right, so let's begin with the some important questions that can be asked from the dermatology. It is going to be a very quick and crisp revision. We are going to discuss about the important questions that has been asked previously, right? So anatomy of the skin, they have asked a question from the anatomy itself. What is going to be the largest organ? This is your largest organ of the body. What is the weight of the skin? This is going to be 4 to 5 kilogram. 4 to 5 kg is the weight of the skin, but the question that they have asked is about the area. What is the area that is covered by the skin, right? What is the area that is covered by the skin? The answer will be 1.7 to 2 meter square, right? 1.7 to 2 meter square depending on the person. So this is the question they have asked you previously, right? So what is the area covered by the skin? 1.7 to 2 meter square, right? What is going to be the weight? We have already discussed, right? Weight of the skin is going to be 4 to 5 kilogram, 4 to 5 kg, right? And it is going to be the largest organ of the body. So what are the different layers we are going to have in the skin? Skin में कितनी layers होती है, कौन से layers होती है? तो superficial, most, the first important one is going to be epidermis. Skin is known as dermis. Derma बोलते हैं ना skin को, तो above dermis will be epidermis, below dermis will be hypodermis, and there will be a junction between epidermis and dermis. This junction is known as dermoepidermal junction. This junction is known as dermoepidermal junction, also known as basement membrane zone, right? So this is going to be the basic anatomical understanding that you should be remembering. Sir, now this epidermis is further divided into various layers. So what are the different layers we are having in the epidermis? You might be hungry, so come, let's grab some burger. This is the mnemonic. Come, let's grab some burger, right? So this is the mnemonic for epidermis, right? This is the mnemonic for epidermis, right? What are the different layers we are having? Come for strata का मतलब होता है बेटा layer. So strata means layer. So stratum corneum is going to be there. Then stratum lucidium. Then stratum granulosum will be there. Stratum granulosum will be there. Granulosum. Then stratum spinosum will be there. And then stratum basal is going to be there. Stratum basal is going to be there. So these are going to be the 5 important layers that we are having in the epidermis. क्या क्वेश्चन पूछा एग्जामिनर ने? एग्जामिनर ने पूछा what is the horny cell layer? What is the horny cell layer? तो horny cell layer is the another name for stratum corneum. Horny cell layer is the another name for stratum corneum. I would be focusing only on the important topics that has been asked previously in NEET PG and FMG examination, right? Next question they have asked you, where is the site for vitamin D synthesis? Vitamin D synthesis के लिए कौन सी जगह location होती है? What is the location? In the option they have written you stratum स्पाइनोसम प्लस स्ट्रेटम बेसिल, दे आर कलेक्टिवली नोन एज मालफीजियन लेयर। तो क्वेश्चन में ऑप्शन था मालफीजियन लेयर। सो वेन एवर दे आस्क यू विटामिन डी सिंथेसिस इज गोइंग टू अकर इन विच लेयर, the answer will be in the Malpighian layer. What is Malpighian layer? It is a combination of stratum spinosum as well as stratum basal. तो दोनों लेयर का कॉम्बिनेशन क्या कहलाता है? This is going to be Malpighian layer. This is going to be Malpighian layer, right? So these are going to be stratum corneum, your lucidium, your granulosum. It will be having lots of granules, you can appreciate, right? This is going to be stratum spinosum, and lastly we are having stratum basal. Stratum basal. So these are the 5 layers that we are having. Another important thing, so what are the other important finding that you should be remembering? Look here, this is stratum, granulosum and spinosum. They will be having 2 keratinocytes are going to be there. They are binded together with the help of desmosome. So this is going to be the desmosome, which has a connection between 2 keratinocytes. So this is one keratinocyte, this is another keratinocyte. How they are binded together? With the help of desmosome. Sir, क्यों important है? Micro में question आया, they have asked you if there is going to be any issue with the desmosomes. अगर इस desmosomes के against toxins बन गए, कौन से toxins? ETA and ETB. एपिडर्मोलाइटिक टॉक्सिन ए एंड एपिडर्मोलाइटिक टॉक्सिन बी, ये आपके लास्ट एग्जाम का क्वेश्चन है. एंड दिस टॉक्सिन इज कमिंग फ्रॉम विच बैक्टीरिया? फ्रॉम द स्टैफ, राइट? सो व्हाट विल हैपन अगर स्टेफाइलोकोकस की वजह से ये होगा? सो द डिजीज विल बी स्टेफाइलोकोकल स्किन स्कारलेट सिंड्रोम, राइट? सो व्हाट विल हैपन अगर ये स्किन है, स्किन विल बी हैविंग मल्टीपल केराटिनोसाइट्स. इफ these keratinocytes are binded together with the help of what? Desmosomes. With the help of desmosomes, अगर इसके against toxin बन गया, which toxin? Epidermolytic toxin A or epidermolytic toxin B. The disease is known as स्टेफाइलोकोकल स्किन स्कारलेट सिंड्रोम, जहां पर आपकी स्किन में पीलिंग होगा, राइट? अनदर थिंग, इफ यू आर हैविंग एंटीबॉडी अगेंस्ट दिस डेस्मोसोम्स, व्हिच एंटीबॉडी? Your IgG and C3 deposits are going to be there. Again the story will be same, your skin will get rupture, but this disease, now this disease is known as pemphigus. अगर एंटीबॉडी दिया हुआ है क्वेश्चन में, योर आंसर विल बी व्हाट? पैम्फिगस. अगर वहां पर टॉक्सिन लिखा हुआ है क्वेश्चन में, यू नीड टू लुक फॉर द कीवर्ड्स. इफ देयर इज टॉक्सिन इन द क्वेश्चन, यू नीड टू मार्क योर आंसर एज स्टेफाइलोकोकल स्किन स्कारलेट सिंड्रोम. दिस इज योर प्रीवियस ईयर एग्जाम क्वेश्चन. लास्ट एग्जाम FMGE में ये क्वेश्चन पूछा था, राइट? नेक्स्ट थिंग वी आर हैविंग, सर व्हाट इज दिस पर्टिकुलर एरिया? व्हाट डू वी कॉल दिस एरिया? First thing you need to remember, stratum corneum is devoid of nucleus. So there is not going to be any nucleus. Nucleus कैसा appear करता है बेटा? In histo you have studied about this thing. Nucleus is going to appear, we are going to stain with the help of hematoxylin and eosin stain, right? So H&E stain we are going to use. Eosin is going to give pink color to cytoplasm, whereas this hematoxylin is going to give blue color to the nucleus, right? So can you appreciate any blue structure in this particular area? There is no any blue color structure in this particular area. That means this is going to be what? No nucleus. So this layer is going to be stratum corneum. Second layer we are having, this is going to be lucidium. Just remember, lucidium is going to be present in palm and soles. This is going to be present in palm and soles. दोनों में L आ रहा है. Lucidium will also have the L, right? So this is how you can remember, it is present in palms and soles, right? Another thing, granulosum will be having granules. We are going to have different kind of granules are going to be there. Spinosum will be having the spinous structures. तो spinous structures क्या होती है? These are the multiple keratinocytes. ये desmosome से जुड़े हुए. So can you appreciate this thing which is coming out like that is going to give you a spine-like appearance? Yes. So this is going to give you a spine-like appearance. These connections due to desmosomes are going to give spine-like appearance. That is why it is known as spinosum. Last layer is going to be basal. Basal will be having certain cells are going to be there. So this is going to be basal. These 5 layers, come let's grab some burgers, are the layers of what? Epidermis. So epidermis will be having how many layers beta? Epidermis will be having total 5 layers. What are 5 layers? You know, these are going to be your corneum, lucidium, granulosum, spinosum and basal. These are going to be the 5 layers. Now we already know below epidermis will be dermoepidermal junction, right? So what is this dermoepidermal junction? Look here, right? This is going to be a junction between epidermis and dermis. This is known as dermoepidermal junction, right? यहाँ से क्वेश्चन पूछते हैं, फिजियो एंड माइक्रो मिक्स करके क्वेश्चन पूछा जाता है. इट इज अ controversial topic, but let me end this for you, right? So I'm just taking this particular area out and let me show you what is going to be the structures we are going to have, right? So the area which is going to be here, this area is known as what? Some cells are present here, some cells are present here, right? So what is this particular area? The part of epidermis which is trying to enter into dermis, this part is known as what? This part is known as rete ridges. So what is this area? This area is known as rete ridges. And which cells are going to be present here in epidermis? The cells are going to be your Merkel cell. So from physiology they are going to ask you this question. What is the location for Merkel cell? It is going to be a part of epidermis or dermis? So your answer will be yes, it is a part of epidermis. Where exactly in the epidermis? It is going to be present in the rete ridges, right? This is going to be the area. Whereas this particular area, this is going to be a part of dermis. This is going to be a part of dermis, and this dermis part is trying to invaginate into the epidermis. This is known as dermal papilla. This area is known as dermal papilla. Dermal papilla, right? And it is going to be a part of dermis. And which cells are going to be present here? These are going to be your Meissner's corpuscles, right? Meissner's corpuscle, right? These are going to be the two important identification. इसके नीचे क्या होगा बेटा? इसके नीचे होगा आपका dermis, and dermis will be having two layer, that is going to be papillary dermis and reticular dermis, right? So dermis will be there. This dermis will be having two important layer. These are going to be your papillary dermis and reticular dermis. So this is the basic understanding that you should be having. How many layers are going to be there? So these are going to be the total layer. This is going to be the basic anatomy so that you can understand the further topics. That is why I have given you this much in detail, right? So this is going to be what? Epidermis. You already know this epidermis will be having 5 layers. Then you have dermoepidermal junction. The part of epidermis which is trying to enter into dermis is known as what? Rete ridges. The part of dermis which is trying to enter into epidermis, this is known as dermal papilla. Is that okay with you, right? Below this particular area will be dermis, and this dermis will be having reticular dermis and papillary dermis. This is the basic anatomical understanding you should be having, right? Another question they have asked you, sir, what is this hypodermis? So another question they have asked you from here, this hypodermis is also known as panniculus. This layer is also known as panniculus, and basically this is also known as subcutaneous. Basically subcutaneous fat will be there, right? So this layer will be having inflammation. They have written a word. What is the word? They have written panniculitis. क्या होता है? What is panniculitis? The answer will be, it is nothing but the inflammation of the subcutaneous layer is known as what? Panniculitis, right? So this is going to be the panniculus and panniculitis, right? All these questions has been asked previously, right? Now, sir, how many cells do we have in the epidermis? You can appreciate here also. Can you appreciate any blue structures here? So no blue structures. That means this is going to be stratum corneum. Then this clear cell layer is going to be there. This is going to be what? Stratum lucidium. Then you have multiple granules. This is going to be stratum granulosum. Then you are having these keratinocytes binding together with the desmosomes. This is stratum spinosum. And last layer we are having is stratum basal. So how many cells you can appreciate in the stratum basal? We are having melanocytes, we are having Merkel cells. So these are the two important cells we are having here, right? Another most important cell is going to be what? Keratinocyte. And the last important cell that we are having in the skin is going to be your Langerhans cells, right? So total how many cells we are having? Langerhans cells, right? So total how many cells we are having in the skin? We are having total 4 important cells in the skin. What are these total 4 important cells in the epidermis? We are having keratinocytes, 90 to 95% keratinocytes. We are having Merkel cell, which is going to be touch receptor. You can appreciate the nerve going from here, right? Another cell is going to be what? Melanocyte, which is going to generate what? Melanosomes. Remember, melanocytes are going to release melanosomes, and now these melanosomes are going to release what? Melanin. And this melanin is going to give color to how many keratinocytes? One melanin will give color to how many keratinocytes? This is going to give color to 36 adjacent keratinocyte, and this is known as epidermal melanin unit, right? This is also an exam question. Very previously they have asked this question in 2019 or 20, right? So this is an old question, right? So what is epidermal melanin unit? One melanocyte is going to give color to 36 keratinocyte, right? So this is going to be important. Now we will discuss about these important 4 cells. So what are these important 4 cells we are having? So we are having keratinocytes, we are having melanocytes, we are having Langerhans cells, we are having Merkel cells, right? So these are going to be 4 important cells that we are having, right? Now this keratinocytes are going to come from where? Another question they have asked is from the location. 2-3 question they have asked in the previous exam from this particular table, right? So what are the important things? First question, keratinocytes are derived from, they are derived from what? Ectoderm. They are derived from ectoderm, right? Merkel cell is also derived from the ectodermal, so both of them are going to be ectodermal in origin, right? This keratinocytes are the most abundant cells, so they are going to be present in all the layers. They are going to secrete what? They are going to secrete the keratin. इनमें से क्या निकलेगा? Keratin, right? And this keratin are the marker for what? From physiology, keratin are the marker for, keratin is a marker for carcinoma. Epithelial cancer is known as what? Carcinoma, right? Epithelial tissue cancer is known as carcinoma. So keratin is a marker for carcinoma, right? Anytime a patient will be having carcinoma, we check for these markers. These are your cytokeratin, right? Cytokeratin 14, we are having cytokeratin 20, right? These are your keratin markers, right? They are responsible for what? Vitamin D synthesis, and their function is to give you the protection, right? Protection, right? Another thing is going to be what? Melanocytes. These melanocytes are going to release what? They are going to release what? Melanosomes. They are going to release what? Melanosomes, and from melanosomes you are going to get what? Melanin, right? So this is going to be the thing we are having. From physiology they have asked you one question, what is the precursor for this melanin? Melanin kahan se aata hai? This is going to come from the amino acid that is going to be tyrosine. So tyrosine is going to make what? Tyrosine will make epinephrine, norepinephrine, dopamine, melanin, your T3 and T4, right? And this thing is going to be present in your tea and coffee. That is why in the morning when we are having tea and coffee, it will activate our metabolic system, right? T3, T4 will be activated, epinephrine, norepinephrine will be activated, your sympathetic nervous system will get activated, and sometimes it can make you black also. So this is why the teas and coffees are going to be responsible, right? But don't forget about your coffee during the exam, right? Excess of coffee can lead to what? Excess of epinephrine, that can lead to sympathetic overactivity. You can have palpitation, you can have anxiety, but make sure you will have some amount of caffeine in your body before the exam. So this is going to help you out, right? It is going to make your tyrosine, and this tyrosine will activate your system, right? So this is going to be important thing we are having. So the question they have asked from this particular area is going to be what? Melanocytes are coming from where? So melanocytes are coming from the neural crest cells, right? Neural crest cells, and they are going to be, location is going to be what? Melanocyte और Merkel cell का location हम लोगों ने देखा था. This is a melanocyte, this is a Merkel cell. Both of them are going to be located where? In the stratum basal, in the stratum basal, right? They are going to secrete what? Melanosomes, and this melanosomes markers has been asked previously in NEET PG examination. What are the markers? These are going to be your Milan A, right? We are having HMB 45, we are having S100. These are the important markers for this melanocytes, right? What else you need to remember? What is the function of melanocytes? They are responsible for UV protection. This is another important question they have asked from here. They are responsible for UV protection, ultraviolet rays protection. So those people who are having already black color, they are protected because they are having enough amount of melanin, and that is going to protect their skin, right? Another thing, it is going to give you definitely the color, right? So these are the two important things they have asked, right? So from melanocyte, two question has been asked previously. One is about this particular one, neural crest cells. Second is most important marker is Milan A, HMB 45. These two are important. S100 is non-specific, right? And third question they have asked is going to be what? UV protection. UV protection is another important thing, right? Next thing we are having is about the Langerhans cells. But Langerhans cells, they are going to be mesodermal in origin. What are Langerhans cells? Basically, they are going to be what? Langerhans cells are monocytes. They are going to be macrophages. Basically they are macrophages. They are antigen presenting cells, right? So they are basically monocytes. When these monocytes will travel to different organs of the body, they are called differently. Monocytes in the liver, we call it as Kupffer cells. Monocytes in the brain, we call it as microglial cells. Monocyte in the kidney, we are going to call it as mesangial cells, right? Monocytes in the skin, we are going to call it as, yes, this is going to be your Langerhans cells, right? So these are the Langerhans cells, and monocytes we already know they are going to derive from the bone marrow or mesodermal in origin. So this is another thing that you need to remember, right? What is the most important location? They are going to be maximally present in stratum spinosum. Maximum amount you will be finding in the stratum spinosum. And the most important finding they are asking you from medicine as well as like sometimes in orthopedics also, and sometimes from dermatology, what appearance you are going to get. You are going to get Burbeck granules with tennis racket appearance. Tennis racket kind of appearance will be there, and these big granules are going to be there. They are known as Burbeck granules. In the medicine, they will write you a disease like what is Langerhans cell histiocytosis, or you also call it as histiocytosis X, right? So what will happen? You will be finding these Burbeck granules and tennis racket appearance will be there. Very important, right? Another question they have asked is about the markers. The most important marker is going to be what? Langerhans or CD207. Another name for Langerhans is going to be what? CD207. CD is cluster of differentiation, right? So CD207 or Langerhans is the most important marker. Another important marker is CD1A. What is the function? They are the macrophages of the skin. So they are going to engulf all the organisms, right? What is Merkel cell? Merkel cells are type 1 slow adapting touch receptor. They are responsible for the crude touch. The marker is cytokeratin 20, and they are transporting what? Neurotransmitter. We already know about the stratum basal. So these 3-4 questions they have asked from here, they are very important, right? So melanocytes are going to be coming from which layer? Neural crest cells. Langerhans cells are coming from the bone marrow or mesodermal in origin. What are the markers? For melanocyte, they are going to be Milan A, HMB45 and S100, right? And the same markers for Langerhans cells is going to be what? CD1A and CD207. These are going to be the important marker. Another question, what is the function of this melanin? Melanin function is to give you UV protection, right? Now we will discuss about some kind of microabscesses. Microabscesses is basically collection of neutrophils or lymphocytes in the body, right? Some small collection, and their location will decide what kind of microabscess we are going to find for the diagnosis of which disease, right? So papillary tip microabscess, this is your last exam question. This is a combined question about dermatitis herpetiformis. So where do you find papillary tip microabscess? Just now I've told you this part is known as what? This part is known as retiridges. This is a part of epidermis trying to enter into dermis, whereas this is a part of dermis which is trying to enter into epidermis. This is known as dermal papilla. So what will happen here? You will be finding some accumulation of pus over here, some accumulation of neutrophils over here, and this is known as what? Papillary tip microabscess, right? For identification of a disease. And what is that disease? This disease is known as dermatitis herpetiformis. Very important. They are asking one or more questions from dermatitis herpetiformis because it has got associations. Let me write some important points about this disease. It has got associations with the disease known as celiac disease. Can anyone name the antibodies which are involved over here? What are the antibodies and what is the treatment? You can expect 5 questions, right? 5 to 6 questions you can expect from derma, right? Celiac disease or celiac sprue we are having, right? So what are the antibodies? In pathology you study about these antibodies: anti-endomysial antibody, anti-TTG antibody, tissue transglutaminase, and anti-gliadin antibody, right? So this is going to be dermatitis herpetiformis. मतलब से क्या हुआ सर? Dermatitis का मतलब होता है there is going to be inflammation on the skin. Herpetiformis means grouped vesicles are going to be there. Herpes का मतलब होता है grouped vesicle. So herpetiformis, grouped vesicles like structures, right? So this is going to have what? Grouped vesicles. Where exactly? On extensor surface around, generally around elbow and knee. So basically this image was given in the question. आपको एक image दिया था and the patient is having this elbow and knee was given, and the person is having multiple grouped vesicle. What is a vesicle? I'll teach you further, right? So multiple grouped vesicle was there, and this disease is having what? Papillary tip microabscess. Your diagnosis will be dermatitis herpetiformis, right? It has got association with celiac disease, right? And the antibodies are anti-endomysial, anti-TTG and anti-gliadin antibodies. And treatment will be avoiding the bro. What is the treatment? Avoid bro. You can also use dapsone, right? Avoid the bro. This is going to be important one, right? Second one is your Munro microabscess and Cogos pustule. Second one is your Second one is your Monro microabscess and Cogos pustules. These two things are going to be seen in psoriasis. Very, very important topic for tomorrow exam. This psoriasis can be there, right? Psoriasis will be having Monro microabscess and Cogos pustule. Whereas this Pottier's microabscess is going to be a type of lymphoma. What kind of lymphoma? This is going to be seen in disease known as mycosis fungoides, right? Mycosis fungoides. It seems like a fungus, but it is not a fungus. It is a cutaneous T cell lymphoma. It is a cutaneous skin T cell lymphoma. It is going to be a lymphoma that we are going to have. This is known as cutaneous T cell lymphoma, where what you will find, some important question, you will find what? Sézary cells. You will have Sézary cells. You will have cerebriform nucleus. Right? These are the keywords you see and you mark your answer. Cerebriform nucleus. Right? And it will show you epidermotropism. That means this is a tumor which will run towards the epidermis. Right? So it will show you epidermotropism, Sézary cells, cerebriform nucleus, mycosis fungoides. This is your Pottier's microabscess, which is a lymphocytic type of microabscess. All three are going to be what? न्यूट्रोफिलिक माइक्रोएब्सेस. बाकी तीनों में न्यूट्रोफिल्स मिलेंगे, यहाँ पर आपको लिम्फोसाइट्स मिलेंगे. लिम्फोसाइट्स इज समथिंग विच विल हैपन आफ्टर अ लॉन्ग पीरियड ऑफ टाइम, है ना. थोड़ा दिन के बाद में लिम्फोसाइट्स जनरली आते हैं और इट विल टेल यू अबाउट द वायरल काइंड ऑफ इन्फेक्शन. न्यूट्रोफिल्स आर गोइंग टू बी acute and they are going to be telling us about some kind of a bacterial entity, right? So this is going to be Pottier's microabscess and your Monro microabscess and Cogos pustules. These two are very, very important, has been asked previously, right? This is going to be the thing. I'll share the notes once we are done, right? I'll try to wrap up. The speed is okay, right? I'll try to wrap up as soon as possible. I know the time is limited and I just want to revise all the things along with you, right? Most of the things are already written, right? This is what we are planning, right? So now we are having some kind of lesions, right? Lesions in derma, right? So what are the lesions we are having? We are having primary skin lesion. We are having secondary skin lesion. Primary skin lesion is a lesion which is due to disease. कुछ disease हुआ, impetigo हुआ, उसकी वजह से कोई lesion हो गया, that is a primary skin lesion, right? So due to disease itself. Whereas what is secondary skin lesion? Secondary skin lesion is a lesion due to inadequate treatment or maybe due to another trauma, right? So this is going to happen because of trauma or inadequate treatment, right? So when you are not treating the things properly, आपने scratch कर दिया, what will happen? This primary lesion will convert into a secondary lesion, right? तो क्या होते हैं primary lesion? Let's try to understand. We are having flat lesion. सबसे पहले कोई भी flat discoloration, छोटा बड़ा कोई भी flat discoloration on the body, hyperpigmentation, कुछ भी हो सकता है, सफेद काला, right? This is going to be known as what? If it is less than 1 centimeter, we call it as a macule. If it is more than 1 centimeter, we call it as a patch, right? अगर लीशन क्लियर फ्लूइड भरा हुआ है, कोई भी लीशन हो रखा है उसके अंदर क्लियर फ्लूइड है, क्लियर फ्लूइड इज telling us about what? Viruses generally, right? There is a simple rule, right? What is the simple rule we are having? Anytime you are having bacteria coming into your body, why bacteria is coming into your body? In the search of food, beta, right? Bacteria is coming into your body in the search of food, right? And what is the food for bacteria? This is going to be glucose. This is going to be glucose. So bacteria कुछ खाएगा तो कुछ ना कुछ बाहर भी जाएगा, right? So what is going to be the thing which is coming out? This is going to be the pus. So bacterial infection will be eating the glucose and will be releasing the pus, है ना? तो ये चीज़ याद रखनी है. दिस इज गोइंग टू हैपन इन ऑल द बैक्टीरियल इन्फेक्शन, राइट? बैक्टीरिया अगर आपके मेनिंजाइटिस हुआ तो भी क्या हो जाएगा? ग्लूकोज कम हो जाएगा, पस ज़्यादा हो जाएगा. सो सिंपल अंडरस्टैंडिंग. whereas the virus is coming into your body for what purpose? Virus is coming into your body for the replication purpose. उसके पास में खुद का मशीनरी नहीं है. It cannot divide on itself, right? So it is coming into your body for division purpose, for replication purpose, and it is going to produce what kind of fluid? Clear fluid. वो खा के कुछ बाहर नहीं निकाल रहा, so that means there is going to be clear fluid. So anytime you are finding any clear fluid, this is going to be generally a viral infection, basic approach, right? Bacterial infections are going to be acute infections. They are going to be painful infection, whereas fungal infections are going to be what? Generally painless infection, and that is the reason they are going to be what? Chronic in nature, right? Fungal infections are going to be chronic, bacterial infections are going to be acute. This is basic understanding you should be having, right? तो कहीं से भी सिंपल क्लियर फ्लूइड इज कमिंग थ्रू योर नोज, आंखों से पानी आ रहा है, नाक से पानी आ रहा है, क्या समझोगे? बैक्टीरियल इन्फेक्शन है. पस आ रहा है, कफ आ रहा है, म्यूकस आ रहा है, दैट इज गोइंग टू बी जनरली अ वायरल इन्फेक्शन, राइट? सो दिस इज गोइंग टू बी क्लियर फ्लूइड फिल्ड लीशन, अगर क्लियर फ्लूइड फिल्ड लीशन है 1 सेंटीमीटर से छोटा, वी कॉल इट एज अ, इसको बोलते हैं हम लोग वेसिकल, इसको बोलते हैं वेसिकल, राइट. इफ इट इज अ बिग लीशन विच इज ऑल्सो अ क्लियर फ्लूइड फिल्ड लीशन, दिस इज गोइंग टू बी नोन एज व्हाट, वी कॉल इट एज अ bulla, right. What is a bulla, right? So this is going to be a clear fluid filled lesion more than 1 centimeter, right. Another lesion is going to be what, कोई solid lesion है, raised lesion है या circumscribed lesion है, गोल गोल lesion है. अगर solid lesion छोटा है, we call it as a papule, that is going to be, small solid lesions are going to be papules, right. We can have papules, multiple papules can happen, right. More than 1 centimeter, this is going to be known as what, plaque. If solid lesion is going to be there more than 1 centimeter, like in psoriasis, what will happen, ये elevated रहेगा surface से, it is not going to be a flat lesion, right. So any kind of solid lesion which is elevated from the surface, you call it as a plaque. This is going to be a plaque, like silver white plaque you will find in the psoriasis, तो वो ऊपर इकट्ठा हो जाते हैं, right. Another thing we are having is going to be, if it is going into the depth, अगर ये अंदर तक invade कर रहा है, this is going to be known as a nodule. So nodule हो गया, papule हो गया, papule is a simple solid lesion which is small, right. Plaque is a solid lesion which is going to be bigger, right. This is going to be plaque. If it is going into the depth, we call it as a nodule. These are the basic understanding. अगर pus filled lesion है, छोटा lesion है, we call it as a pustule. अगर बड़ा lesion है, we are going to call it as a, if it is a big lesion, we are going to call it as a abscess, right. So we can have pustule, we can have abscess, right. What is a wheal? Wheal is a itchy. These three keywords you need to identify in the question. Itchy, erythematous, edematous lesion. Itchiness होगी, erythema होगा, redness will be there, right, and edematous lesion is going to be there, that means edema is going to be there, this is going to become a wheal. ये क्या बन जाएगा, wheal. What is a petechia? You can have petechia less than 2 mm का अगर कोई lesion है, we call it as a petechia. You can have multiple petechial rashes in which disease, like in the cases of dengue, you can have a tourniquet test, you will be finding multiple petechial rashes. This is more than 20, is going to be suggestive for some severe disease, right. So this is going to be, if there is a red dot, small dot less than 2 mm, we call it as a petechia. If it is 2 to 5 mm, we call it as a purpura. If it is going to be more than 5 mm, you are going to call it as a ecchymosis, right. What is going to be a cyst? Any lesion which is covered by the epithelial cavity, this is known as what, cyst. This is known as a cyst. So these are the primary skin lesion you need to remember. What are secondary skin lesions? We can have scales. What is scale? Scale is going to be what, this is going to be, scale means desquamation of stratum corneum, desquamation of stratum corneum, right. stratum corneum इकट्ठा हो जाएगी तो क्या बना देगी, स्केलिंग बना देगी, और stratum corneum will be there, right. So this is known as scaling, ऊपर ऊपर के layer. What is crusting? Whenever there is going to be any substance coming up, right, blood आ रहा है, pus आ रहा है, dried up any substance, dried up exudate is known as what, crust, है ना. हनी कलर्ड crust is seen in, try to answer, हनी कलर्ड crust is seen in. तो कहीं से भी कोई भी पस आएगा, वो सूख जाएगा तो क्या बना देगा, this is going to be known as crusting. This is known as crusting, right. What is erosion? Erosion is going to be loss of epidermis is known as what, erosion. Loss of epidermis is known as erosion, right. Excoriation क्या होगा, अगर linear loss हो गया epidermis का, we call it as a excoriation, right. What is lichenification? 3 identification. ये क्वेश्चन आता है एग्जाम में, lichenification का एक फोटो दे देंगे, they will ask you what is identify the lesion, right. So अगर lesion में itchiness दे रखा है, कलर चेंज दे रखा है, और erythematous lesion है, right, red lesion is going to be there, or some color change is going to be there, itchy lesion is going to be there, this is known as what, lichenification, which is a secondary change, right. What is a scar? Scar is a permanent fibrotic change that will happen post a disease, right. अगर hypertrophy हो गया scar में, what do you call it? Hypertrophic scar is also known as what beta, right. Another thing we are having is ulcer. What is ulcer? Ulcer is loss of epidermis plus dermis, दोनों का involvement is known as what, ulcer formation, right. So these are the basic lesion, primary and secondary skin lesion we are having, right. What is hypertrophic scar is known as, hypertrophic scar is known as what beta, this is known as keloid, right. And how you are going to treat the keloid, क्या दोगे keloid के treatment में, right. Then we are having all the scaling, right. ये scaling आपके question में मिलेगा आपको, they are going to write you the person is having this kind of scalings, right. So try to answer. Scaling का मतलब क्या होता है? Scaling का मतलब होता है pityriasis. So sometimes you will find pityriasis alba, pityriasis rosea, pityriasis something like that, right. So what you need to remember, versicolor, right? So what do you need to remember? This is going to be meaning what? Scaling. And scaling का मतलब क्या है? Epidermis ऊपर आके इकट्ठा हो गई. This is known as what? Scaling, right? So in ichthyosis, what kind of scaling you are going to get? In ichthyosis vulgaris, you are going to get fish-like scale. Fish-like scales are going to be there, right? This is going to be seen in the ichthyosis. In psoriasis, in the question you will find anywhere silver white scale. Your answer will be what? Psoriasis. Several white scales are going to be feature of psoriasis. Pityriasis versicolor, you will be finding what? Rice powder. Very important. Rice powder or brany scales or fine scaling is going to be there. Fine scaling is going to be there. This is going to be suggestive of pityriasis versicolor, right? And pityriasis rosea, you will be having what? Pityriasis का मतलब तो क्या है? Scaling है, right? Rosea मतलब R for R, you can remember. Here you will be having red color scales are going to be there, right? So this is going to be cigarette paper like scale. Cigarette paper like scaling will be there, or sometimes they can also write you colorate of scale, right? Color like scales are going to be there, right? So whenever you will find collar like scale, your answer will be pityriasis rosea. Cigarette paper like scale, answer will be pityriasis rosea. Pityriasis versicolor, very important. These two topics, they are frequently asked in the examination, right? Because they are confusing, you will confuse. Both of the lesions are going to have what? Trunk involvement. एक में red color का lesion होगा, एक में hyperpigmented lesions are going to be there, right? तो याद रखना पिटाइरियसिस मतलब तो स्केलिंग है. वर्सिकोलर मींस डिफरेंट कलर इज गोइंग टू बी देयर. हाइपो एंड हाइपर पिगमेंटेशन विल बी देयर. वेयर एज रोजिया, याद रख लो, रोजिया में कैसा दिखेगा? ट्रंक इज गोइंग टू अपीयर red in color, right? R for rosea, R for red in color will be there, right? So these are the basic all kind of scaling that you are going to find. We have written it here, and this is going to help you out directly, right? Just go through this PDF once before the exam, and these important topics are going to get covered, right? Another lesion we are having, annular lesion किसको बोलते हैं? The lesion which is going to have active margin. बाहर का एरिया एक्टिव है और सेंट्रल क्लियरिंग है, बीच का एरिया ओके क्लियरिंग है, outer margin is going to be activated. This is known as annular lesion. ऐसे lesion को annular lesion बोलेंगे. अगर पूरा एरिया active है, if the whole area is going to be active, this lesion is known as what? Discoid lesion or nummular lesion, also known as coin shaped lesion, right? So where do you find this type of lesion? In the tinea corporis, in the leprosy, in the urticaria, you will find the annular kind of lesion, whereas whole lesion is active. This is known as discoid lesion. That would be a finding in the cases of DLE, discoid lupus erythematosus. Now comes the most important topic. I hope this is clear to you, right? These images you can see, you can identify. This is a clear fluid lesion more than 1 centimeter. We call it as a bulla. This is a flat lesion less than 1 centimeter. We call it as a macule, right? This is going to be a vesicle, clear fluid lesion less than 1 centimeter. We call it as a vesicle, right? So all these things are going to be there. You can watch the images, right? Another thing we are having is very important topic. This is known as Papulosquamous disorder, and the most important one that we are going to see over here is going to be what? Your psoriasis. Psoriasis is an important one, right? It is an autoimmune disorder. Most common site is going to be which surface? Outer surface. This is going to be generally seen in the extensor surface. You can expect one question from here. What is the most common type of psoriasis you can have? The most common type of psoriasis is psoriasis plaque psoriasis, or also known as psoriasis vulgaris. Vulgaris का मतलब क्या होता है बेटा? Vulgaris means most common, right? What are the findings you are going to have? The mnemonic is polished, right? What is polished? P for pitting is going to be there. What is going to be there? P for pitting. The depression on the nail is known as what? Nail bed में जो depression that you can appreciate, these are known as what? Pitting. It is a most common finding of psoriasis. Another important finding is going to be what? O for oil drop sign is going to be there. What sign will be there? Oil drop sign. This sign is known as what? Oil drop sign. Very important. 2 times are asked in the FMGE NEET PG examination. 2 times the same image they have given you, right? This sign is known as oil drop sign. It is the most characteristic lesion. If they ask you most common lesion, the answer will be what? Pitting. This is your most characteristic lesion. If they ask you most characteristic lesion, this is known as oil drop sign. This is also sometimes written as salmon patch. इसी को हम लोग क्या बोलते हैं बेटा? Salmon patch. So this is the most characteristic lesion of the psoriasis, right? L4, this is going to be what? L and I, you will be having what? O and L together. You can remember OL is going to be what? Onycholysis. Onycho मतलब नाखून होता है. Onycho means nail. Lysis means breakdown of the nail. So what will happen? Look here. Here this nail is going to get broken, right? Nail broke. This is known as what? Onycholysis. देखो एक सिंपल तरीका बताता हूँ. What is going to happen? Normally in psoriasis, what will happen? The skin transit time is going to get reduced, right? Epidermal transit time will reduce to 4 days. Normally it is going to be 28 days, right? तो normally 28 दिन में skin ऊपर की तरफ आएगी from the basal to the corneum normally, right? In a normal individual, from the stratum basals to the stratum corneum, this is known as epidermal transit time, right? अब psoriasis में क्या होता है? ये skin 4 दिन में ऊपर आने लग जाएगी. This skin is going to come within 4 days. This is going to get accumulated. अब ये कहाँ accumulate होगी? Stratum corneum पे. अब ये अगर accumulate होगी below the nails, what will happen? In nails के अंदर you will be having keratin deposition. Keratin deposit हो जाएगा और उसकी वजह से नाखून टूट जाएगा. The same thing will happen on the skin. जहाँ पर भी lesion है वहाँ पर क्या होगा? This stratum corneum will come and get deposit और उसकी वजह से आपको एक superficial structure मिलेगा. This is going to be a plaque formation and that plaque is going to give you appearance of silver white color, right? So this is the basic pathogenesis problem that is going to happen. Epidermal transit time will get reduced to 4 to 8 days. In some books it is written 4 to 6 days, right? तो बेसिकली ये स्किन आके इकट्ठा हो गया और उसकी वजह से नाखून ऊपर की तरफ चला जाएगा या फिर ये टूट जाएगा, राइट? Another thing, eye for this is going to be what? You will be having pitting, and this pitting is going to be what? Regular or irregular? This pitting is going to be what? Irregular pitting. And last important thing is going to be S and H. This is going to be what? This is going to be what? Subungual. Subungual means below the nail. Hyperkeratosis. Hyper means increased. Keratosis means keratin deposition. You already got the concept why this thing is happening, right? So this is going to be the polish. Even if you are not able to remember the polish, you should remember PSO. This P for pitting beta, S for subungual keratosis, and O for oil drop sign. These three are very, very important. The most common is going to be pitting and most characteristic is going to be oil drop sign, and as you can remember, S for subungual hyperkeratosis, right? So this is going to be the basic identification, right? Now this type of lesions you are going to find, and these lesions are known as what? These are your silver white scaly lesions are going to be there. There is going to be a ring around this particular area. This ring is known as worn-off ring. What do you call it? Worn-off ring, right? And there will be a membrane over this ring. The membrane is known as what? Berkeley's membrane. There will be a membrane over it. This membrane is known as Berkeley's membrane. So naam yaad nahi ho raha, it's okay, it's fine, right? No issues. But the test you should always remember, when you will take a glass slide and you try to scratch this particular lesion, what will happen? This Berkeley's membrane is going to get removed and you will have what? This pinpoint bleeding spot. Very, very important characteristic finding. Pinpoint bleeding spot is going to be there, and this pinpoint bleeding spot is known as what? This is known as which sign? This is known as Auspitz sign. Very, very important thing, right? Auspitz sign is going to be there. So what is Auspitz sign? When you try to rub the Berkeley's membrane, what will happen? Pinpoint bleeding spots are going to come up, and this is known as what? Which sign? This is known as Auspitz sign. Auspitz sign is going to be there, right? These are important thing, right? If you look at this particular one, this area of epidermis which is trying to enter into dermis, this is known as rete ridges. Can you see here? You will find long elongated rete ridges, right? So what are the findings on histopathological examination? First finding is elongated rete ridges. Elongated rete ridges are going to be there. Second important finding is going to be what? I told you about the Kogo's pustule, right? So this is going to be what? This is going to be your Kogo's pustule. This is going to be accumulation of neutrophilic abscess. This is known as Kogo's pustule, right? Another accumulation you will find over here. This is going to be known as Munro microabscess. This is what we have seen, right? And what is parakeratosis? We already know the nucleus should be absent in stratum corneum, but here you are finding nucleus in the stratum corneum. This is known as parakeratosis, right? So these are some important keywords you need to remember. Parakeratosis means presence of nucleus in the stratum corneum. This is a feature of psoriasis. You will be having Munro microabscess. Munro microabscess. You will be having what? Kogos pustule. These are going to be the important finding you will be finding in the cases of psoriasis, right? You will find these keywords and some history. All this is going to make sense, and this is going to be what? This is going to be a diagnosis of what? Psoriasis. Many questions has been asked from this particular slide, right? What are the different kind of psoriasis we are having and how you are going to approach to this particular one? The first one is scalp psoriasis. This is going to be one where you will be giving what? Steroids to the patient. This is important one. This gutter-like lesions you are going to find on the back after a upper respiratory tract infection. If someone is going to give you some history of upper respiratory tract infection, upper respiratory tract means from the nose to the larynx, right? From the nose above the larynx is going to be what? Upper respiratory tract. From the larynx to the alveoli is going to be lower respiratory tract infection, right? So someone is going to have upper respiratory tract infection. Along with that, he will develop this gutter-like lesions, right? This is known as gutted psoriasis. And they have asked you the treatment of choice for this particular one. The treatment is going to be what? इसमें हमको क्या देना है? इसमें हमको एंटीबायोटिक्स देना है पेशेंट को. वी नीड टू ट्रीट दिस सिचुएशन and automatically the patient will be fine, right? So you understand about the scalp psoriasis and gutted psoriasis. What is pustular psoriasis? Sir, pus is also coming on those silver white lesions, right? So pus is also coming on silver white lesion. Remember, here they will ask you what is the drug of choice. The drug of choice is acetretin. And remember, this is a vitamin A analog, and vitamin A is fat soluble vitamin. Yes or no? Yes, it is a fat soluble vitamin. It will store in your body. Where exactly? My dear doctors, tell me where what is the site for vitamin A storage in the body? Where do you think it is going to get stored in the? This is a vitamin A derivative stored in the stellate cells of liver. Stellate cells of liver, and they are going to get stored over there, and this is going to be the reason. It is a fat soluble vitamin, can store in your body. It will be teratogenic till 3 years, right? If someone is taking these drugs, they will be having teratogenic effect till next 3 years, right? So this is going to be the drug of choice for pustular psoriasis. Acetretin, very important, right? Isotretinoin we already know, but acetretin is also important one, which is a very long period of teratogenicity that you will be finding, and vitamin A storage is going to happen in the stellate cell. That is also has been asked in the biochemistry. Just for the remembering purpose, you can remember this, right? What is this what is this inverse psoriasis? I told you the psoriasis, the most important surface is going to be extensor surface, but if it is happening on the internal surface, this is known as what? Inverse psoriasis or flexural psoriasis, right? This is going to be the drug of choice is going to be what? Methotrexate is the drug of choice, right? Then we are having erythrodermic psoriasis. The erythro मतलब होता है red, derma means skin. So if psoriasis will be with this red skin, this is known as erythrodermic psoriasis, right? And impetigo herpetiformis is what? Impetigo means superficial infection is going to be there. Herpetiformis means grouped vesicles you will be finding. So here you can find, here you can find, here you can find grouped vesicles. So this is psoriasis and pregnancy. Here also you can use what? Steroid. We cannot use methotrexate because that is going to be teratogenic again, right? It can kill the baby also, right? So these are the important pointers that you need to remember about the psoriasis, right? These are the important things you need to remember here, right? Another important entity we are having is about the lichen planus. Lichen planus, what is lichen planus? It is going to be a 6P disease. Lichen planus is going to be a 6P disease, right? 6P disease, right? What are the 6 P's you need to remember? These are going to be what? These are going to be having plain, purple, polygonal, pruritic papules are going to be there. Papule means solid lesion. Plain means they are going to be, sometimes they can write you flat topped. In the question they can write you flat topped lesions. Purple, they can write you violaceous. Violet color or purple color lesions are going to be there. They are going to be polygonal. Pruritic lesions are going to be there. Pruritic papules are going to be there. So this is going to be what? This is going to be plain purple polygonal pruritic papules are going to be there on the extensor surface. Remember beta, this lesions are going to be where? This is going to be seen more commonly on the extensor surface, right? So this is going to be what? Sorry. extensor surface, the most common lesions are going to be what? They are going to be psoriasis, right? These are the lesions you will be finding, right? And another important thing about this particular lesion is going to be what? This pterygium. What is this pterygium? Pterygium means what? When this proximal nail fold is going to divide this nail into two half, right? Can you appreciate this proximal nail fold is dividing the nail into two half, right? This is known as pterygium. It is the most characteristic finding of what? This is most characteristic finding of psoriasis. This is most characteristic finding of psoriasis. Sorry, lichen planus. This is most characteristic finding of lichen planus. For psoriasis, that is going to be what? That is going to be oil drop sign or Salmon patch, right? What is this Wickham striae? You will be finding some oral involvement also, and you will be having white reticular lacy pattern. White reticular lacy pattern will be there. Now, this is not Kaposi sarcoma. When you will find this white reticular lacy pattern on the mucosal involvement, this is going to be known as what? Wickham striae. We will discuss further about Kaposi sarcoma also, right? That is going to be HHV8, right? On the histopathological examination, you will be finding what kind of retridges will be there. Can you appreciate? These retridges are appearing as a sawtooth. So, what are the findings you will be having? Here you will be having sawtooth retridges. Sawtooth retridges. Another finding is going to be cevate body. Don't forget this name. This cevate body has been asked previously in your last exam, right? So what they have written? They have written cevate bodies are going to be a feature of. In the question, they have written cevate bodies are a feature of. This is a histopathological identification feature of lichen planus, right? And you can also remember Max Joseph cleft. So this space is known as Max Joseph cleft. This body is known as cevate bodies, and this is known as sawtooth retridges are going to be there. They are going to be a feature of what? Lichen planus. What we have seen in the psoriasis will be having elongated retridges will be there. You have mucormycoabscess, you can have Cogos pustule, you can have parakeratosis. For this particular one, these things are going to be the keywords that you should be remembering. Agar itna yaad reh gaya, kaam ho jayega, right? So this is going to be what? Lichen planus. What about this pityriasis rosea? I told you pityriasis का मतलब होता है scaling. Rosea मतलब red color lesions are going to be there. So you can appreciate here this person is having this red color lesions are going to be there, right? Important thing, the first patch is known as what? The first lesion that is going to be there is known as what? First lesion is known as mother patch or herald patch. The first patch is known as mother patch or herald patch, and then you will be having lesions in a pattern of a Christmas tree, right? So this type of pattern you will be finding. So Christmas tree pattern is going to be there. So other lesions are going to be seen in the Christmas tree pattern or fir tree pattern. So other lesions are going to be seen in the Christmas tree pattern. What are the differentiating features? Here you will be having scaling. Scaling is going to be there. What kind of scale? Here you will be having cigarette paper like scales are going to be there. What kind of scales are going to be there? Cigarette paper like scales or collarate of scales are going to be there. Collarate of scales or cigarette paper like scales is a feature of pityriasis rosea, right? It has got some association with the HHV7. HHV7 has got some association with this pityriasis rosea, and this is going to be associated with what? The treatment is going to be you apply what emollients or basic steroids, and this thing is going to get treated, right? So this is going to be all lichen planus and pityriasis rosea. The next important thing we are having is about the other infections. What are these infections? We can have what? Simple infection, single hair nodule is involved. This is going to be what? This is known as folliculitis. Folliculitis, this is a pus like infections due to Staph aureus it can happen, right? If it is going to involve the complete hair structure, this is going to become what? This is known as furuncle. This is known as furuncle. If two hair nodules are going to get involved, this is going to become what? Two hair follicle are involved, this is going to be known as carbuncle, right? So we can have folliculitis, we can have furuncle, we can have carbuncle. What is treatment? Basic treatment is going to be what? You can use amoxis 625. This is going to be what the treatment for this folliculitis, basic folliculitis or carbuncle, right? Generally this carbuncle is going to be happening on the nape of the neck in those people who are having diabetes mellitus. That means more amount of glucose will be there. More glucose means more bacteria will come. More bacteria means more lesions can be there. So this carbuncle is common in diabetes mellitus patient, right? So these are your folliculitis, furuncle and carbuncle, right? Another question they are asking is about the impetigo. What are the different kind of impetigos we are having? We can have bullous impetigo, we can have non-bullous impetigo. Bullous का मतलब क्या बताया था? Bulla means there is going to be a fluid filled lesion is going to be there, right? So just remember this bullous impetigo is going to be what? Due to staph infection. This is due to staph infection, and this non-bullous impetigo is going to be due to strepto, more commonly due to streptococcal infection. Here you will be finding what? Honey colored crusting is going to be there. So honey colored crusting is going to be common in streptococcus infection, and this is going to be superficial epidermal infection. तो यहाँ पर क्या होगा बेटा, lesion होने के बाद में क्या होगा, this pus is going to come out and this pus is going to get dried up and it is going to give you a honey colored appearance. So this is going to be a feature of non-bullous impetigo is due to strepto, and whereas bullous is due to staph. This is going to be the basic understanding, right? Then you can have what? You can have cellulitis versus erysipelas. Very, very important. Cellulitis is going to be a superficial infection or a deep infection. It is going to be a deep infection going deeper till the subcutis, right? Whereas the erysipelas is going to be what? Going till the lymphatics. So this is going to be what? Superficial. This is going to be kind of superficial kind of infection. Superficial. Right? Here you can find the demarcated margins, or margins are going to be easily visible, right? Here you will be having what? Diffuse margins are going to be there. So this is how you can differentiate between these two important one, and they are going to be different. The cellulitis more commonly seen with the staph organism, staph, whereas this erysipelas is seen with the strepto, right? These are the basic differentiation features you should be remembering, right? Here you will find the signs of inflammation. You will be having temperature, you will touch this, you will be having inflammation. All these things are going to be there, right? So this is how you can rule out. The treatment remains same. You can use what? Amoxicillin for the same, right? Another thing we are having is erythrasma. What is this erythrasma you are going to have? Erythrasma is due to which organism? It is due to a bacteria. The name of the bacteria is Corynebacterium minutissimum. The name of the bacteria is Corynebacterium minutissimum, right? This is the bacteria which is going to cause what? This erythrasma, right? And it is going to give you coral red fluorescence. What is the appearance that you are finding here? This is your coral red fluorescence. Under which examination? This examination is known as wood lamp examination. Very favorite of the examiner, right? This is going to be wood lamp examination, and you are going to get the coral red fluorescence, right? What is the light you are going to use? You are going to use UV light here. Which light you are going to use? Ultraviolet rays are going to be there, right? And what this color is going to be there? It is due to some pigments, and this is going to be what? Reddish brown color due to keratolysis. Keratin टूट गया, उसकी वजह से ऐसा color आएगा, right? Some other bacterial infections that you can appreciate over here. First is going to be staphylococcal skin scarlet syndrome. I told you here you will be having here you will be having toxin production, ETA and ETB, against the desmoglein or desmosomes, leading to what? Exfoliation of the skin, right? And this exfoliation is going to show you a sign positivity. What is that sign positivity? It is going to be Nikolsky positive. It is going to be Nikolsky positive. Whereas the next syndrome is going to be Steven-Johnson and Ten syndrome, right? Ten and Steven-Johnson. It is going to have less than 10% of the skin body surface area is covered. We call it as a Steven-Johnson. That can be due to drugs also. If it is involving more than 30% of the area, peeling of the skin is happening on the, or necrolysis is happening on the more than 30% of the area, we call it as a 10, and overlap is going to be between 10 to 29% is going to be known as what? Overlap syndrome. What about this anthracis? These are two important lesions, two black important lesions they are asking you, right? They will tell you the history. In the last exam they have given you the history. There is a farmer who is going to the forest, right? And after coming from the forest, you are finding some black color lesion, right? So there are two important black color entities that you should be remembering. What are those two important black color entities we are having? The first one is going to be anthracis, another one is going to be what? Another one is going to be what? Scrub typhus, right? So दो black color के lesion याद रखने. Here you will be having black color scar will be there in the anthracis. This is going to be due to this is due to Bacillus anthracis bacteria. You can have intestinal anthracis, you can have pulmonary anthracis, you can have cutaneous anthracis, right? So this is going to be cutaneous anthracis, and that can will give rise to malignant pustule or black color lesion basically. And this disease that you will be finding here is going to be what? Hide Porter's disease, right? So those people who are carrying the hide means what? Skin, right? Hide means skin of the animals they are carrying. They will be having this bacillus anthracis coming in contact, and they will start to have what? Some kind of a lesion यहाँ हो जाएगा या बैक पे हो जाएगा जहाँ पर वो कैरी करके लेके आ रहे हैं. So this is going to be what? Malignant pustule. Okay. Another black lesion they can ask you, दो याद रखने हैं. दूसरा black lesion they can ask you, they can write you the patient is having black color scar, patient is having erythema, redness is going to be there, some signs of the infection. These are going to be fever, malaise, lymphadenopathy is going to be there, right? This is going to be going in the favor of what? Scrub typhus. And this scrub typhus will also have the black color scar, right? This mark we need to identify. हम patient की body पे देखते हैं. If we will find this mark, this is going to be what? Scrub typhus. Other we can go for further identification also for antigen, right? The treatment is going to be what? Doxycycline, and the mite is going to be what? Orantia shushugamushi. What is the mite that you are going to have? This is going to be Orantia shushugamushi, right? Doxycycline. This doxycycline you are also giving for two important organisms. Let me summarize exam point of view. One is going to be what? Brucella. Very important. Brucella is going to give you a long-term fever. Another important organism that you need to remember is going to be what? Leptospira. Leptospira question also they are asking multiple times. So this leptospira is associated with the rat urine, paddy fields, right? Rice field, paddy fields, rat urine. They are you will find these words. Important word is conjunctival suffusion. If you are finding redness in the conjunctiva, your answer should be what? Leptospira. So these are some organisms that you should be remembering just before the exam. Leptospira is very, very important. For brucella and scrub typhus, the drug of choice is going to be what? Doxycycline. If they ask you any black lesion in a patient coming from in a farmer coming from the from the jungle or somewhere, right? This is going to be what? Anthrax or scrub typhus. These two things you have to remember, right? What are the treatment for pyoderma? Basically for pus-like infection, you can use what? Fusidic, you can use mupirocin, or you can give oral antibiotics like amoxiclav, right? Now some fungal infections we are having. We are done with the major part of bacterial infection. Fungal infections are going to be what? They are going to be pityriasis versicolor. Just now I told you about the pityriasis rosea. This is the second one, an important one that we are having. This is known as pityriasis versicolor. So what happens in pityriasis versicolor? What is the causative agent here? Excuse me. What is the causative agent of pityriasis versicolor? The causative agent for pityriasis versicolor is going to be what? This is going to be, they've asked you this particular question. This is going to be Malassezia furfur and Malassezia globosa, right? These are the causative agent. And pityriasis means what? Pityriasis means scaling is going to be there. Versicolor means different color. So you can have what? Hypo and hyperpigmented patches on the trunk, right? Pityriasis rosea, red color patches will be there. Pityriasis versicolor, hypo and hyperpigmented patches are going to be there. And this too, because this fungus is going to produce acid, this acid is known as azelaic acid. Azelaic acid is responsible for hypopigmentation. Quasic acid, azelaic acid, right? They are going to be skin whitening agents that we can use as, right? So these are going to be what? Azelaic acid we are having. Most common site is going to be what? Obviously it is going to be present on the trunk, right? And for the treatment you can use what? Azoles. For the treatment you can use what? Azoles, right? These are going to be the azoles, right? Under KOH examination you are going to find what? When you will put this thing on the KOH, you are going to find a very specific and classical appearance. This is known as spaghetti. This is known as spaghetti and meatball appearance, beta. What is the appearance you will be finding? Spaghetti and meatball appearance under the KOH examination, right? When you will put the same thing on the microscopy with some olive oil, you are going to get what? You are going to get fried egg colonies, right? Fried egg colonies. Now exam is tomorrow. Try to answer me where else you will find this fried egg colonies, right? Two important thing. One is in the mycoplasma. One is in the mycoplasma beta, right? Another thing from the pathology, there is a tumor. This is known as oligodendroglioma, non-which tumor that is going to have what? Fried egg appearance is going to be there. Oligodendroglioma. So these two are the important one, right? These are your fungal infections. These are going to be called differently in different location. If it is happening on the groin area, this is known as tinea cruris. This is known as tinea cruris, right? If it is happening on the body, this is known as tinea corporis, right? If it is happening on the nails, generally seen in the athletes, this is going to be known as tinea pedis, right? The treatment for tinea, the treatment is going to be what? Terbinafine, right? The drug of choice is going to be terbinafine. We can also use azoles, but remember for tinea capitis, head infections like Favus or Carrion, right? For Favus or Carrion, we are going to use what? Grisio fulvin, because it is going to have high keratin affinity towards the head, and basically head will be having more keratin, so grisofulvin will be acting better, right? In Favus and Carrion, just remember that causative agent for Carrion also, this is going to be your Tinea mentagrophyte or Tinea verrucosum, right? These are the important points, right? The next thing we are having is about the parasitic infection. The two important parasitic infections we are having is going to be, first one is going to be Prince Itch disease, also known as your scabies. Scabies is due to an organism. This organism is known as Sarcoptes scabies, right? And the location is going to be what? Circle of Fabra, right? Very important. The person is going to have this particular location below the neck. These are the areas where you will find this type of lesion, right? You will be having intense itching, very intense itching. This is also known as 7-year itch disease or Prince itch disease, right? So this patient will be having intense itching. Family history, just look in the question. If they are writing you family history is there, one or more children in the family is having the same kind of itching problem, and you can also identify this in the stratum corneum. You can have what? Burrows. What are these burrows? They are the most characteristic lesion. They are the most characteristic lesion. They are known as burrows, right? So if you will find these burrows, this is going to be suggestive of what? Scabies, right? And for the treatment of scabies, you can use what? 5% permethrin lotion, right? So you can use what? 5% permethrin. You will give it to the person, and this person is going to apply below the neck, and next day they are going to wash it off, right? And they also need to wash all the clothes into the hot water, right? What is this Norwegian scabies? It is going to be what? Worst prognosis we are having, and this thing will happen due to inadequate treatment or maybe due to steroid intake, right? So this is going to be what? Norwegian scabies, also known as crusted scabies. This is also known as crusted scabies. Norwegian, also known as crusted scabies, right? Then we are having this disease. This disease is due to the louse, and this disease is known as what? Pediculosis. What is this pediculosis? Here you will be having what? This itching will be there on the head, generally happening in the school going children's, right? It can happen in those people who are not taking care of the hygiene also, right? This is going to be what? Due to head louse, you can have pediculosis capitis. Due to body louse, you can have pediculosis corporis. Corporis matlab body, and these are going to be pediculosis pubis can also happen. And the most characteristic lesion that you can appear here is going to be your macula seriola. Macula seriola is the most characteristic lesion you are going to find. The treatment remains same. The treatment will be 1% permethrin. In scabies, you will give 5% permethrin. Here we can use 1% permethrin, right? Another thing we are having is about the viral infection. Whenever you will find this kind of pearly white umbilicated nodules, right? Pearly white umbilicated lesions, this is going to be telling us about umbilicated lesions, is going to tell us about what? This is going to tell us about a disease known as molluscum contagiosum. Molluscum contagiosum, right? And what is the meaning of molluscum? Molluscum matlab hota hai soft. Contagiosum means what? Highly infectious. So they are going to be what? They are going to be soft and highly infectious lesions are going to be there, generally happening in the children's, right? These are the lesions with the central dip. With the central dip, this lesion is known as what? Molluscum contagiosum. क्या बोलेंगे? Molluscum contagiosum. And the bodies you will be finding here are going to be what? They are going to be your Henderson-Peterson bodies. What are these bodies known as? Henderson-Peterson bodies are going to be there. HP bodies, right? Treatment is going to be, you can use trichloroacetic acid. We can also use podophylotoxins, or cryotherapy is also indicated here, right? These are cosmetically not good. That is why we are trying to remove them, right? Next is very important infection and a hot topic that can be asked in your examination. This is going to be what? HPV. HPV is going to have certain strains like the mnemonic is DSP, come eat a burger, right? So this is going to be the mnemonic. We are having HPV 1, 2, 3, 4, 5, 6, 7 like that, right? Important one. We are also having HPV 16 and 18. They are going to cause what? CA cervix, right? That is going to cause what? CA cervix. We can have 611. They can also cause anogenital warts. They can also cause what? Laryngeal warts, right? This HPV 4 is known as going to cause what? Common warts. An examiner has given you a word, verruca vulgaris. Verruca means warts. Vulgaris means most common warts is due to. The answer will be it is due to HPV 4, right? And now we are having a vaccination that is going to be there for all the females who are going to have what? For the prevention of CA cervix due to this HPV vaccination. So we are having some strains like we are having the cervarix like for 1618 we are having 611, 1618. This is going to be your Gardasil. We are having Gardasil nonavalent, also Gardasil 9, that is going to work against the 9 variants. In India, we are currently using this particular one for all the sub centers we are having, all the PHCs we are having, will be having this particular 611, 1618, which is currently being given to the people, right? This is an important update that you need to remember, right? Then we are having this human herpes virus. Herpes means what, beta? Herpes means grouped vesicles. So anytime you will be finding grouped vesicles. Vesicle का मतलब क्या होता है? Clear fluid filled lesion less than 1 centimeter is considered as a vesicle, right? So whenever you will find multiple grouped vesicle, this is going to be what? This is going to be herpes. If it is happening around the mouth, this is going to be known as herpes labialis. Multiple grouped vesicle around the mouth is herpes labialis. Grouped vesicle around the mouth, this is going to be what? Herpes labialis. This is due to HSV1 infection. Herpes will be having total 8 members in the family. Total how many members? 8 members, right? So above the waist is going to be what? You can remember above waist you can have 3 infections above waist. Important one. First is going to be in the eye. You are always studying about ulcer. This ulcer is known as what? You can have dendritic ulcer. This is going to be what? Dendritic ulcer. Very beautiful ulcer you can have. And this herpes can also enter into your brain. It can cause what? HSV encephalitis, which is going to involve your generally your temporal lobe and more specifically your hippocampus. Hippocampus, right? And what is the function of hippocampus? Yes, it will be present on YouTube after the class. You can watch it, right? Hippocampus has got a function of conversion of short-term memory into long-term memory. And here comes the second advice: try to sleep well today, right? Whatever you have read today will be able to convert into long-term memory if you are able to sleep today very properly, right? So try to go to the sleep just after the session, have dinner, and just try to go to the sleep, right? This is what we are going to discuss further, right? We are having HSV2 infection. HSV2 is going to be below the waist infection. It can cause what? Genital herpes. You can have genital herpes, right? HHV3 is going to also known as varicella. This is going to cause what? Chicken pox, and the appearance is going to be what? Dewdrop on rose petal appearance. Here you will be having polymorphic rashes are going to be there. Multiple morphology rashes are going to be there. So this is going to be polymorphic rashes, right? What can happen? You can have shingles. What is shingles? Reactivation of this varicella is known as what? Shingles. Reactivation is known as shingles, right? What is this zinc smear? Zinc smear is going to be coming out to be positive. You will be finding multinucleated giant cells or acantholytic cells under the microscopy, right? Singles will be herpes zoster. Herpes का मतलब होता है multiple grouped vesicle. Zoster means along a nerve segment. So you will find multiple grouped vesicle along a nerve segment. This is going to be a nerve segment, right? This is known as herpes zoster, right? Herpes zoster. HHV8 is going to be there. HHV8 is known as what? Kaposi sarcoma, right? Generally, this purple plaque is going to be there happening on the body in those people who are having already some kind of a immunodeficiency is going to be there, है ना? जिसका immunity down है उसमें ये हो जाएगा. AIDS patient हो गया, cancer patients are going to be there. They can have what? Kaposi sarcoma. The treatment remains same, right? The first thing you can give, you can use for these things, you can use what? Acyclovir. Apart from that, the important treatment is going to be treat the underlying disease, right? Okay. So treatment you can use what? Heart therapy, highly active antiretroviral therapy, right? And you can also use what? Anti-cancer if there is a case of cancer, right? HHV5 is also known as cytomegalovirus. Very important. CMV going to happen in those people who are very immunodeficient. CD4 count is going to be somewhat around 50. CD4 count is around 50, right? CD4 count अगर 200 दिया हुआ है तो क्या सोचोगे बेटा? CD4 count, if it is 500, this is going to be what? This is going to be TB. This is going to happen, most common opportunistic infection, that is going to be TB. If the CD4 count is given in the question around 200, think about pneumocystis cerevisiae pneumonia or plasma cell pneumonia, ना? ये याद रखना है, दो चीज़ें, right? Treatment for this particular one, this is going to have what? CMV will be having owl eye inclusion bodies. These are your owl eye inclusion bodies, and the treatment is going to be what? Ganciclovir. For all other herpes, you can use acyclovir. For this particular one, you can use what? Ganciclovir, right? The next important viral infection we are having is HFMD. What is this HFMD? This is going to be hand, foot, mouth disease, right? If the hand, foot and mouth is given in the picture, you need to mark what? HFMD, right? If hand and foot is given, this is might be a case of what? Secondary syphilis, condyloma lata, right? Okay, so we can have what? Coxsackie A16 and enterovirus 71. Here the patient will be having vesicular multiporphic rashes are going to be there on the palm, soles, buttock and oral cavity. Very, very important, has been asked previously about the HFMD, right? Then we can have this oral hairy leukoplakia. This is going to be having what? This corrugated appearance is going to be there. White color lesion with this kind of a corrugated appearance, white corrugated plaque is going to be there, which is non-removable. This is going to be happening generally in HIV patients. This is known as what? OHL or oral hairy leukoplakia, right? Lateral border of the tongue is going to get involved. This is a leukoplakia. Leuko means white color lesions are going to be there. This parvo B19 is going to give you the very important slapped cheek appearance. Bilateral slapped cheek appearance is going to be there, or you can have malar rash, right? Reticular rash. This is going to be also known as erythema infectiosum. Erythema infectiosum. The next important disease we are having is leprosy, beta. Leprosy is due to Mycobacterium lepra, right? Here you will be having chronic inflammatory disease is going to be there. You can have two types of leprosy. If it is involving less number of lesions or no nerve involvement, this is going to be what? This is going to be paucibacillary. If it is going to involve the nerves, it is going to involve the nerves and number of lesions are also more. We call it as a multibacillary leprosy. So what is going to be different in both of them? The treatment part. Treatment for paucibacillary is going to be 6 months, whereas for multibacillary it is going to be 12 months, right? What about this particular one? Rifampicin. We can give rifampicin, clofazimine and dapsone. The drugs remain same, but the treatment course is going to be different. For paucibacillary it is going to be 6 months. For multibacillary it is going to be 12-month treatment, right? Rifampicin we are going to use 600 milligram per month. 300 milligram per month is going to be what? Clofazimine. They are going to be given in the hospital. And for the dapsone we are going to give 100 milligram, 100 OD. This is going to be the basic treatment, and 50 milligram per day they are going to take it home, right? Once the patient will be going to the home, they are going to take 50 milligram of clofazimine and 100 milligram of dapsone. That has been asked previously, right? So this is going to be the treatment protocol. But what happens in leprosy, right? What happens in Hansen disease or leprosy? This is going to be the same thing. So here you will be having hypoanesthetic, means decrease in sensation, hypopigmented lesions are going to be there, which will involve the nerves. You can have lateral loss of eyelashes, you can have lateral loss of eyelashes, you can have metarosis, you can have saddle nose, you can have claw hand, you can have foot drop. Why this thing is happening? Because it is going to involve the nerve, right? And the most important nerve, radial nerve, is going to get involved. You can have what? Claw hand can happen, you can have foot drop, sea pain can get involved, ulnar nerve can get involved, right? You can have what? Claw hand due to ulna, and basically you will be having wrist drop due to radial nerve, right? So this thing can happen. What are the stains we are going to use? Staining means giving color, right? If we are using 5% of H2SO4, leprosy is 5% acid fast. You can remember lepra, LEPRA. This is going to be what? 5% acid fast. So this is going to be also known as F45, F4 fight Furaco stain. This stain is also known as fight Furaco stain, right? How you will make the diagnosis? You are going to take the smear from different parts of the body, your ear lobule, your eyebrows, your chin, right? And we are going to put it under microscope for identification. And how you are going to grow it? Under 9-banded armadillo. But this armadillo is not available very nicely in India, right? So we are going to use some jugaad. What is the jugaad we are using? Newborn suckling mice we are going to use for the diagnosis of this particular thing, or for the culture of this particular thing, right? Next thing we are having, what are the things it is going to get target? Your skin, papillary skin and peripheral sensory nerves are going to be there, right? Hot and cold is going to get affected, and the fibers which are going to get affected are going to be your A delta and C fiber, which is going to carry fast pain. This is going to be A delta fibers. C fibers are going to carry slow pain, right? Another important question they are asking from here is about the lepra reaction. So whenever you are going to take dapsone, clofazimine, or the drugs like rifampicin, what will happen? Your body will be having bacteria. This bacteria will fight with the drugs, right? This will cause some kind of reaction. So we can have two types of reactions due to treatment. These lepra reactions are due to treatment, right? So what are these lepra reactions? We can have type 1 lepra reaction, we can have type 2 lepra reaction. Type 1 is going to be a type 4 hypersensitivity, just make it 5, and type 2 is going to be type 3 hypersensitivity, you just need to make it 5, right? So what can happen in type 1 lepra reaction? You can have redness on the body, you can have nerve pain, right? Earlier patient is not having any kind of pain, but after taking the treatment, patient will start to have pain, so patient will generally leave the treatment, right? In type 2 lepra reaction, you can have erythema, nodosum, leprosum, right? You can have what? Multiple painful corps of nodules are going to be there on the body. The patient will be having painful lesion. It is a hypoanesthetic, hypopigmented lesion was there in the patient. वो आपके पास आता है, आपने एक दवाई दिया और पेशेंट को डिसीज हो गया. पेशेंट will feel more symptoms, pain हो रहा है, दर्द हो रहा है, right? So what patient will do? He will stop the treatment. But what is going to be the consequence? Patient can enter into saddle nose, loss of eyelashes can happen, claw hand can happen, wrist drop can happen, foot drop can happen, right? All these things can happen, right? So we need to tell our patient, no need to stop the treatment, you just need to continue the treatment. We will also add on something, some drugs we can add on. If you start to have some kind of adverse reactions, just do come back to us, we will give you some other add-ons, but don't stop the treatment, otherwise you can have what? Severeness of the situation can get worsened, right? This thing can happen, right? So what is the treatment? They are asking in type 1 lepra reaction, you are going to give the steroids, but type 2 treatment, they are more focusing on the drug that you are going to use is going to be what? Thalidomide. And the side effect of this thalidomide is going to be what? Phacomelia or phocomelia, which is going to be the C limb deformity that can happen, right? And the name of the classification that we are going to use for leprosy is known as what? This name has been asked previously. क्या कौन सा classification हम लोग use करते हैं? Leprosy. This is known as Ridley-Joplin classification used for the leprosy, right? Another classification you can remember for known mycobacterium bacteria. This is going to be known as what? Runyon classification. These two classification question they have asked you. Runyon classification is used for, so this is used for known tubercular mycobacteria, right? So they are not going to cause what? TB, non-tubercular mycobacteria. This classification is known as Runyon classification. The classification you are using for this leprosy is known as Ridley-Joplin classification. Okay, so these are your 5 types of leprosy. We are having TT, BT, BB, BL, and LL type of leprosy. These are the different kind of leprosy we are having, right? The next thing is about the STDs. What are the different kind of STDs we can have? We can have herpes simplex virus, we can have chancroid, we can have staphylococcus, we can have donovanosis, we can have LGV, right? So two things you have to see when you are trying to solve this kind of question. You need to look for two things: whether the ulcer which is going to be painful or painless. Just remember this thing, you will be able to solve all the question. If the ulcer is going to be painful, there are going to be two situations. One is going to be herpes is painful, another one is going to be chancroid is painful. These are the two ulcers which are going to be painful, right? Herpes you can see and identify. I told you the meaning of herpes is what? Grouped vesicle. So whenever you will find grouped vesicle, multiple grouped vesicle, your answer will be, sir, it is a herpes case. It is a case of herpes. Whereas chancroid, you will be having again multiple ulcers are going to be there. So painful multiple ulcers, whenever you will find, this is going to be what? Either herpes, either chancroid, right? If chancroid is going to be there, you can have what? Multiple ulcers with undermined edges, right? Generally here you will be having unilateral lymphadenopathy also, right? It can be bilateral as well, but generally it is going to be unilateral lymphadenopathy. You need to focus on what? Chancroid. This is going to be chancroid. For painless ulcers, you can have two entities. Painless and single are going to be together, right? So two things can be there. One is going to be what? One is going to be, it can be donovanosis. Another entity is going to be there, that is going to be syphilis, right? If it is going to be a case of syphilis, they will write you there is going to be what? Short T or rubbery lymph node. Short T lymph node or rubbery lymph node is going to be there, right? If it is going to be a case of donovanosis, how you will differentiate? Here they will write you beefy red ulcer. Beefy red ulcer will be there, which will bleed on touch, which will bleed on touch. So when you touch this ulcer, this is going to be a very red ulcer is going to be there. Here both of them are going to be painless and single, both of them are going to be multiple and painful. This is how we can differentiate. And the last which is left is going to be what? LGV. This LGV will be having what? Transient ulcer. That means this ulcer will not be persisting for a longer period of time, but this person will be having what? L for L, lymphadenopathy will be there, and which is going to be bilateral and painful, right? So this is how you can appreciate and answer these questions, right? So herpes simplex virus is going to be there, bilateral painful ulcer, multiple ulcers are going to be there. This is incubation period, the pain is going to be there. For chancroid also it is going to be painful. Unilateral buboes are going to be there. Unilateral lymphadenopathy is going to be there. They are going to be multiple, right? For syphilis and donovanosis, they are going to be painless ulcers, right? Bilateral rubbery shorty lymph nodes are going to be there. Here you will be having pseudobubos, but the important thing is going to be what? They are going to be beefy red ulcer. They are going to be bleeding on touch, right? And for LGV, you are going to have transient ulcer, which is bilateral painful lymphadenopathy, right? So basic understanding: painful multiple ulcer, these two things should be there in your head. Painless single ulcer, these two things should be in your head. No ulcer, only lymphadenopathy, this is going to be what? Case of LGV, right? Now another important entity we are having is about the vesicobullous disorder. Vesicle का मतलब हमको पता है छोटा, right? Vesicle is going to be small. Bulla is going to be what? Bulla is going to be bigger, right? Bulla is going to be bigger, right? So we can have pemphigus, we can have pemphigoid. These are the two group of disorders we can have. So simple understanding that you need to have, right? What we have seen, we are having what? Epidermis, we are having dermoepidermal junction, and we are having dermis, right? This is what we already know about the skin, right? So what will happen? This pemphigus is going to be what kind of a disorder? This is going to be, and then we are having dermis, right? So this pemphigus is going to be a epidermal disorder, right? So pemphigus is going to be, S for S, you can remember, it is going to be a superficial disease. Just focus on the keywords that I'm giving you, will be helpful for your examination, right? It is going to be a superficial disease, whereas pemphigoid is going to be a deep disorder. It is going to be a deep disorder. Where is going to be the antibody? Where is going to be the lesions? Here the antibodies are against the desmosomes, against the desmosomes. So here which antibodies are going to be there? IgG and C3 deposits are going to be there against this desmosomes, and this disease is known as what? Pemphigus. Whereas in pemphigoid, what is going to be the thing? These keratinocytes are binded together with the desmosomes, they are normal. But when they are going to connect with the basement membrane zone with the help of hemidesmosomal proteins, so here the antibodies are going to be against what? Your hemidesmosomal proteins like BPAG1 and BPAG2, and these hemidesmosomal proteins are going to have the same antibody, IgG and C3 deposit. Now this disease is known as what? Bullous pemphigoid, and this disease is known as what? Pemphigus. This is how you can differentiate between these two, right? Another important things that you can appreciate in the examination, if they will write you flaccid bulla, if they will write you in the question flaccid bulla is there, this is going to be what? Pemphigus disorder. If they will write you tense bulla, this is going to be what? Tense bulla in the question, this is going to go in the favor of pemphigoid disorder, right? This is going to be intraepidermal. If they will write you there is an intraepidermal cleft, intraepidermal lesion, this is going to be what? Pemphigus. Whereas if they will write you subepidermal, below the epidermis, means on the basement membrane zone, this is going to be what? Pemphigoid disorder, bullous pemphigoid, right? So this is how you can differentiate. In the question you find flaccid bulla, mark the answer pemphigus. If you find IgG C3 against desmosomes, mark the answer pemphigus. If you will find BPHE, BPHE2, this is going to be bullous pemphigoid. You will find somewhere tense bulla, you will find somewhere subepidermal disorder, mark the answer pemphigoid, right? This is how you can differentiate. Now further differentiation of this pemphigus, you need to remember about these two disorders. We are having pemphigus foliaceus, we are having pemphigus vulgaris. So what you can remember, this foliaceus and vulgaris, you just need to remember the epidermal layers, right? So what are the layers we are having? Come, let's grab some burger. These are the layers, and we already know this lucidium is present only in the palms and soles, so we can skip this out, right? So we are having these layers are going to be there. So just remember this foliaceus is going to be involving what? A stratum granulosum, right? So here in pemphigus the disorder is going to be where? In the stratum granulosum. So can I also call it subcorneal disorder? Can I also call it subcorneal disorder? Yes. So this is going to be foliaceus, where antibodies are formed against desmoglein 1, which is majorly present on the stratum granulosum. Whereas in the cases of vulgaris, the problem lies where? In the stratum spinosum. The problem lies in the stratum spinosum. So whenever they want to ask you a question about vulgaris, they will write you the problem in the spinosum. Either they can also write you suprabasal disorder. So suprabasal disease is going to be there. What is going to be your diagnosis? So suprabasal means it is not going to be what? Foliaceus. It is going to be what? It is going to be vulgaris. This is the only thing you can remember, right? If you can remember this, this is going to fetch you 1 mark, right? So if they will write you the problem lies in the granulosum, this is going to go in the favor of foliaceus. If the problem lies in the spinosum, this is going to go in the favor of vulgaris, right? What are the other things you are having? Remember this mucosal involvement is a feature of what? The mnemonic is minar. So mucosal involvement is a feature of vulgaris. And here the antibodies are going to be against what? Desmoglein 3. What antibodies? Again the antibodies remain same. These are going to be your IgG and C3 deposits are going to be there. So what is the mnemonic we are having? Minar. M4, mucosal involvement is there. Both of them are intraepidermal disorder. Mucosal is only found in the vulgaris vita, right? And for Nikolsky is positive. What is Nikolsky positive? Nikolsky means when you apply the tangential pressure, what will happen? The skin will get ruptured, because in the epidermis you are having damage that will lead to skin rupture. We can have acanthocytes. These are going to be your simple keratinocyte cells, and raw of tombstone appearance. Very important. So let me show you what is this raw of tombstone appearance and what is going to be the findings you will be having. So what is this Nikolsky sign? When you apply the tangential pressure, it is going to go away. This is known as Nikolsky sign, right? Another, acanthocytes are going to be there. These cells are going to get separated because they are connected with the help of what? Desmosomes. So when these cells, these keratinocytes are separated, we call them acanthocytes, right? Raw of tombstone appearance, this is going to give you this kind of appearance, and this is the same appearance we are finding over here also. That is why it is known as raw of tombstone appearance. In the DIF, what you will find very specific fishnet pattern, right? So try to identify, if you can identify here. This is going to be what? Epidermis. This is your dermoepidermal junction, and below will be dermis. And this is going to be the layers that we have already discussed in our histopathological identification, right? The part of epidermis which is trying to enter into dermis is known as what? Retirigis. Yes, the part of dermis which is trying to enter into epidermis is known as what? Dermal papilla. So what will happen? This is a pemphigus. We have already discussed, we are talking about pemphigus. So where is going to be the disorder? In the basement membrane zone or in the epidermis? Yes, we have already seen pemphigus is a epidermal disorder, right? So what will happen here? You will be having these keratinocytes are going to be there and desmosomes are going to be there. So this deposition is going to happen where? In the epidermis, and that is going to give you a fishnet kind of a pattern, right? So that is why we are going to have a fishnet kind of a pattern, and the treatment is going to be what? Steroid. Another question they have asked you is about the anti-CD20 molecule that you can use in the cases of pemphigus. This is going to be what? Rituximab in the cases of pemphigus, right? What about this bullous pemphigoid? We already know here the deposition lies in the epidermis or in the basement membrane zone. So here you can appreciate the deposition is happening, DIF, the deposition is happening on the basement membrane zone because the problem lies in the basement membrane zone, right? So this is going to be what? The antigen, the IgG and C3 deposits are going to be formed against BPAG1 and BPAG2, and they are going to be present specifically in the basement membrane zone. That is the reason we are going to get a linear kind of a pattern on DIF, right? So linear IgG deposition on the DIF, right? What kind of bulla will be there? We already discussed. This is the bullous pemphigoid, so tense bulla are going to be there, right? Treatment will be again steroids you can use, right? This is going to be what? This is going to be the bullous pemphigoid. What kind of bulla? This is a clear fluid filled lesion more than 1 centimeter. We call it as a bulla, right? Last thing we are having is about linear IgA disease. So linear IgA means what? The picture remains same under DIF because the location remains same. So here what will happen? The antibody will be different. Earlier it was IgG and C3 deposit, but here it is going to be IgA deposit. On which ground? This IgA deposit is going to be there here, right? And this this disease is known as what? Linear IgA disease, right? Antibodies are against the same BPAG1 and 2 because they are going to be present here. BPG2, right? So this is going to be linear IgA disease, right? What kind of appearance we are going to get here? This is going to be string of pearl or beaded appearance is going to be there. This is going to be important. Bimodal approach is going to be there. In the children it can happen, in the adult it can happen, right? So this is going to be linear IgA disease, right? Last important thing we are having is going to be dermatitis herpetiformis. We have discussed this. What kind of microabscess you will be finding? This is going to be what? Papillary tip microabscess, right? So this is going to be retiragus. This is going to be dermal papilla, right? So what you will find in the dermal papilla, you will be having what? Accumulation of neutrophilic microabscess. This is known as papillary tip microabscess. It has got associations with celiac disease. These are your HLAs. Important HLAs are going to be there. DQ2 B8 is going to be there. These are your antibodies: anti-endomysial, anti-TTG, anti-gliadin antibodies. Treatment will be dapsone you can give. You can avoid the bro, right? And the symptoms and the image that has been asked in the exam, they have given you the same image. Multiple grouped vesicles are going to be there. This is going to be what? Linear this is going to be dermatitis herpetiformis. Herpetiformis means grouped vesicles are going to be there on the extensor surface with this particular one. This is going to be what? Dermatitis herpetiformis, right? Now some hyper and hypopigmented disorders that we are having. Hyperpigmentation mein kya yaad rakhna hai? You have to remember about this particular one. This is happening around the pregnancy. This is known as what? Melasma. This is known as what? Melasma. If it is happening in the pregnancy, we call it as cloasma. We call it as what? Cloasma, right? So we can have melasma, we can have cloasma. Just give me a moment. We can have melasma, we can have cloasma. Just give me a moment. Let me just fix the camera. Just a minute, guys. Give me a moment, I'll be back. Within some few minutes, guys, camera will be restarting, right? Till then, we will continue, right? Hyperpigmentation, if it is happening around the pregnancy, we call it as cloasma, right? If it is happening due to some OCP intake, this thing is known as what? Melasma, right? And chick sign, when another question they have asked you is about the chick sign. What is this chick sign? When you will be having hyperpigmentation on the nose after chikungunya, this is known as chick sign. What is the spots on the back? These are known as Mongolian spots. They are self-limiting, that you need to remember, right? You will tell your parent, you will tell your patients that it will be self-limiting. Within 1 year it will go away, right? Nevus means there is going to be discoloration. If it is happening around the eye, we call it as a ophthalmic branch. You can ophthalmic, O for eye you can remember, ophtha you can remember. So this is going to be nevus of ota around the eyes. It will involve the 2/3 of sclera, right? And the nerves are going to be V1, V2 and trigeminal nerves, right? These are the parts, right? Another thing, we are having acanthosis nigricans. Acanthosis means what? Thickening of stratum spinosum, and nigricans means black discoloration. So this thing is due to diabetes mellitus, malignancy. This thing can be internal marker for malignancy as well, right? So this is going to be thickening of stratum spinosum, which is known as acanthosis nigricans, right? And nevus of Ito. ईटे पीछे से उठाते हैं बैक पे, you can remember like that. So this is going to be what? Nevus of Ito, where you will be having supraclavicular nerve involved, which is a lateral branch of cutaneous nerve that is going to get involved over here, right? What about this Baker's nevus? B for Baker's में क्या आ जाएंगे बेटा? You will be having hairs, बाल आ जाएंगे, right? So you can remember like that. So the nevus with the hairs is known as Baker's nevus. Nevus का मतलब होता है discoloration, right? So it can be unilateral. It can be a acquired nevus. Acquired मतलब this is going to happen after the birth. अभी भी हो सकता है, right? This thing can happen now and anytime this thing can happen. This is known as Baker's nevus, right? What about these particular one? They will be asking you what is pyabaldism. Pyabaldism, just remember this white forelocks. White forelocks in the Indira Gandhi, you can remember. This is going to be what? A disease, pyabaldism, right? This thing is happening because of a neural crest problem, right? Melanocytes are not able to come from the neural crest. This is the first problem. Second problem, the melanocytes are going to have what? Antibodies, right? This is going to be, the disease is known as what? Vitiligo. Vitiligo is going to be there. If it is going to be localized, that means on a particular location, right? This is known as localized or focal vitiligo, right? Focal means कोई कोई जगह पर lesion है, right? Segmental means it is happening around a particular nerve segment. We call it as a segmental vitiligo. They can give you a picture and they can ask you what kind of vitiligo is this. Third one is acrofacial, on the extremities. Acro means on the extremities and facial, right? So this is happening on the extremities. Remember, generalized, whenever you will call it generalized, it is going to be what? Bilateral. The bilateral one, you are going to call it as a generalized vitiligo, right? Next thing we are having is about, this is going to be what? This is going to be albinism. Next thing is going to be what? Albinism, right? This albinism will be having problem with the tyrosinase enzyme. I told you tyrosinase is responsible for production of what? Melanin, right? If tyrosine is not going to be there, there is going to be no melanin, and leading to what? Leading to this white, complete white discoloration is going to be there. There is no melanin. That means there will be no color in the person, right? There will be this person is going to become white, right? So this is going to be problem with the melanogenesis, right? And that is due to tyrosinase enzyme, right? Now we can have what? Eczema. Eczema का मतलब होता है बेटा inflammation of the skin, right? Eczema means what? Inflammation of the skin is going to be there. So we can have acute eczema, we can have chronic eczema. Acute eczema, you can have erythema, edema, and crusting can happen. In chronic, you can have lichenification. लंबे समय तक कोई itching करेगा, secondary change will be there, color change will be there, edema will be there, erythema will be there. This is known as what? Lichenification. But the important classification is based on the substances. It can be exogenous eczema, bahar se kuch ho raha hai. Endogenous eczema can also be there. So exogenous eczema, we call it as a contact dermatitis. This contact dermatitis itself is divided on two important types. It can be due to some irritants. Irritants matlab it is going to be a known immune reaction, right? Direct contact can lead to this thing, right? So suppose you are touching the detergent and you start to have peeling of the skin. This is going to be irritant contact dermatitis, right? Diaper can lead to this nappy rash can happen in the babies. This is also going to be irritant contact dermatitis. Whereas what about this allergens? Allergic contact dermatitis, it can be due to metals, it can be due to dyes, it can be due to plants, pollens, multiple things can be there, right? And how you will diagnose this? This is going to be diagnosed on the basis of a test. This test is known as what? Patch test, that you can appreciate here. This is known as patch test. This is a patch test that we are doing for identification of allergic contact dermatitis, right? Treatment is going to be what? Avoid the triggers is the best treatment. Then you can give the antihistaminics to the patient, right? Just remember one thing, this allergic contact dermatitis is a type 4 hypersensitivity reaction. This is going to be which kind of hypersensitivity reaction? This is going to be a type 4 hypersensitivity reaction, right? Let's see if it is working now. It is going to be a type 4 hypersensitivity reaction, right? Treatment is going to be just avoid the triggers, right? Whereas endogenous eczemas are going to be what? They are going to be like seborrheic dermatitis, pityriasis alba, we are having nummular dermatitis, atopic dermatitis. The important thing from here that you need to remember, atopic dermatitis is a type 1 hypersensitivity reaction, whereas contact dermatitis is a type 4 hypersensitivity reaction, right? Okay. Diagnosis with the help of a criteria. This is known as Hanifan and Rajka criteria. Very important. Just remember the name, right? This is going to be Hanifan and Rajka criteria. What are these lesions that you can appreciate over here? These are going to be your basal cell carcinoma, which is also known as what? Which is also known as rodent ulcer. Basal cell carcinoma, also known as rodent ulcer, right? Very important. This is your basal cell carcinoma, right? You can simply excise this particular lesion and you are going to be cancer free because of this particular one, right? Whereas this squamous cell carcinoma, early diagnosis, better treatment can be there, but the most dangerous that you can appreciate here is going to be what? This melanoma. And they will ask you one question, how to differentiate between a melanoma versus a mole, right? So we are going to use a criteria that is known as what? ABCDE criteria, right? This is going to be ABCDE criteria for differentiation of, just remember the name, melanoma versus mole. So this is the criteria we are using for this particular one, right? Now, most important thing, another direct questions they have asked you is about fixed drug eruptions, some miscellaneous questions, right? So what is this FDE, fixed drug eruption? Is going to be a type 4 hypersensitivity reaction. This is going to be a type 4 hypersensitivity reaction. right? It can be due to NSAIDs, cotrimoxazole, tetracycline, right? These are the drugs which can cause this particular reactions. What is erythema multiforme? This is going to be a cytotoxic kind of dermatitis. It is associated with HSV-1 infection, right? You can have target lesions on the palms and soles. These target lesions are important. Erythema chronicum migrans, erythema matlab redness, chronicum migrans means it will be traveling in the body, right? It is also seen in which disease? That is known as Lyme's disease, and this Lyme's is due to what? Borrelia burgdorferi, right? Borrelia burgdorferi, which is having a lashing motility, right? Xantha lesma, xantha matlab hota hai yellow, lesma is going to be what? Yellow discoloration around the corner of this medial border of the eye, right? This thing is going to happen. It is a feature of what? It is telling us about what? Hyperlipidemia in the patient. Patient is having hyperlipidemia. You can have what? Xanthelasma kind of lesions are going to be there. What is this phrynoderma? This is going to be toad-like skin you will be finding. This is going to be due to vitamin A deficiencies. You can have hyperkeratotic papules are going to be there. Papules means solid lesions are going to be there on the extensor surface around the elbow, right? So this is going to be phrynoderma. What is the erythema nodosum? You can have these red color nodules on the anterior aspect of the leg, generally associated with the streptococcus and many other diseases, right? What is this necrobiosis lipodica diabeticorum? Big name, right? This is going to happen on the anterior aspect of the leg. This type of lesion, they have given you picture, and this is going to be what? This is necrobiosis lipodica diabeticorum, right? Diabeticorum. What is this cutis marmorata? This is your last to last NEET PG question, right? This is going to be happening, marbling kind of situation happening in a baby in response to the cold environment. In response to the cold environment, this thing can happen. This is known as what? Cutis marmorata, right? Cutis marmorata. Okay, last important identification. This is going to be what? STD color kits by NSCP that we are having, right? Some new advancement we are having here is going to be what? This kit number 8, which is going to be the brown color kit, which is a new add-on that we are having. Earlier we used to have what? 7 STD kits we used to have, right? These STD kits are going to be your gray, green, white, blue, red, right? White, blue, red, you can also remember, you can also recall your Reynolds phenomena, right? What happens in Reynolds phenomena? You will be having the same sequence, white, blue, white or pale blue and red, same sequence. So first is going to be gray color, second one is going to be green color, third, fourth, fifth is for white, blue, red, sixth one is going to be yellow, black, and the last kit we are having is brown color kit, right? What happens in gray color kit? It is going to be for organisms, for any kind of discharge coming from the urethra, right? So this is going to be for urethral discharges majorly. Kit number 2 is for the vaginal discharges. What are the basic vaginal discharges you can have? You can have what? You can have bacterial vaginosis, you can have trichomonas vaginalis, you can have what? Candida. But this candida is going to be a fungal infection which is characterized by intense pruritic lesions or intense itching will be there. So we can also identify thick white gutty discharge with intense itching. You can give what? The treatment will be what? Fluconazole 150 milligram, right? This is going to be the treatment. For these two, you can give what? Metronidazole. But this metronidazole you need to give for such a long period of time, right? So what we are going to do here, we are going to make this drug as we are going to give, instead of metronidazole, we can give a sekinidazole, which is a alternative 2 gram sekinidazole. Single dose is going to be enough, right? So this is what we are going to give, right? Sekinidazole 2000 milligram or 2 gram. You can remember that this is going to be what? This is going to be the treatment. Kit number 3 is the white color kit, which is for the genital ulcers. Now genital ulcers which are non-herpetic, right? Non-herpetic means what can happen? Non-herpetic means herpes is not going to be there. If herpes is not going to be there, there is going to be chancroid, there is going to be syphilis, there is going to be donovanosis, right? For syphilis, we already know the drug of choice is benzathine penicillin G, so it will be having benzathine penicillin G, right? Kit number 3 will be having penicillin G, and for chancroid and donovanosis, we can use what? Azithromycin, so it will be having benzathine penicillin G along with the azithromycin. Kit number 4, if a person is allergic to benzathine penicillin G, right? If person is allergic to penicillin, we can give what? Instead of penicillin, we are going to change it to doxycycline, right? This is what we are going to give to the patient. Kit number 5 is for herpetic ulcer or grouped ulcers, right? Group genital ulcers, this is going to be herpes. Herpes, the treatment remains same, 400 milligram TDS for 7 days. This is going to be the acyclovir that we are going to give here, right? For kit number 6, we are going to have PIDs. PIDs mean pelvic inflammatory diseases or lower abdominal pain. It can be due to bacteria, we give cefixime. It can be due to amoeba, we give metronidazole, right? So this is what we can use along with the doxycycline, right? Black number kit is for the LGV, the LGV which is only going to have what, inguinal buboes, right? So inguinal buboes, LGV kind of symptoms, we can give what, doxycycline, which is a kit number 7. And for any kind of anorectal discharge, we can give what, kit number 8, which is having what, cefixime is going to be there and doxycycline is going to be there. So these are some STD kits that we are having, right? Let me fix the camera now, just give me a minute. I hope it would be working now. So we are done with the dermatology. It's working now. You can see me, right? So we are done with the dermatology, right? And important points I've tried to cover here, right? Most important points. Now I will discuss about some exam strategy points. You are so close to the victory. Don't you dare to give up now, right? Some people will be like in a state, they will be having anxiety and all those things, right? So it is going to be normal to have this particular kind of anxiety. It is going to be okay, right? No need to worry. Whatever you could do, right? आपने जो पढ़ना था, whatever you could study, you have already studied. You are done with this, right? So this is going to be a time when you will give yourself a relief. You will tell yourself that whatever I want to do, जो भी मैंने करना था वो हो गया बस, now हो गया, right? अभी इसके बाद में कुछ नहीं है, इसके बाद में वी आर गोइंग टू पास दिस एग्जामिनेशन, है ना? एक पॉजिटिव माइंडसेट के साथ में वी नीड टू स्लीप टुडे सो दैट वी आर गोइंग टू क्लियर दिस एग्जाम टुमारो, राइट? व्हाट इज गोइंग टू बी द टाइमलाइन फॉर द बिग डे that is going to be tomorrow? What are the things you are going to do, right? Now after this particular session you are going to have maybe you have done your dinner. If you have not done your dinner, just try to complete your dinner and go to the sleep, right? Try to sleep early, because I already know that most of you are trying to sleep, but this is not going to happen very easily. If you go to sleep by 9:30, that is how you are going to get the sleep by 12:30, राइट? 2-3 घंटे एंजाइटी में, थिंकिंग में, ओवर थिंकिंग में जाएंगे ही जाएंगे. तो मेक श्योर यू कम टू द बेड अर्ली, है ना? अगर आप जल्दी बेड पे जाओगे, यू आर गोइंग टू स्लीप अर्ली, राइट? वंस यू विल स्लीप अर्ली, यू विल वेक अप अर्ली. दिस इज वेरी वेरी इंपॉर्टेंट. You need to wake up early tomorrow, right? Because if your mind will see, don't touch your mobiles after like after dinner. You see something and just keep it aside, right? No need to look for other things. जो भी होगा देखा जाएगा, है ना? वो बाकी चीज़ें नहीं सोचनी है. बाकी चीज़ें सोचोगे क्या होगा? You will look at your mobile, you will see it is going to be 2 a.m. और अब दिमाग में कैलकुलेशन चलेगी कि 6 बजे उठना है, एंड योर ब्रेन विल गेट द मैसेज कि मैं 4 ही घंटे सोया हूँ, राइट? दिस इज गोइंग टू क्रिएट एंजाइटी टुमारो, राइट? सो वी आर नॉट गोइंग टू टच अवर मोबाइल. चाहे सुबह नींद आए, बट उठने के बाद में यू हैव टू टेल योर सेल्फ, नहीं मैं सो लिया, वट एवर आई नीड टू स्लीप, आई एम डन विद एवरीथिंग, आई एम गुड, राइट? वो चीज़ आपको बोलनी है, राइट? ओके. सुबह उठने के बाद में नो नीड टू स्टडी लॉट ऑफ थिंग्स. बहुत सारी चीज़ों में इधर उधर नहीं जाना है, बिकॉज याद कुछ होगा नहीं और पूरा ब्रेन क्रैम्प कर जाएगा, राइट? सो मेक श्योर वॉट एवर इंपॉर्टेंट सेट ऑफ नोट्स और थिंग्स दैट यू आर हैविंग, बस उन्हीं को अपन को देखना है एक बार, अगर देखना है तो. अगर नहीं देखना तो दिस इज गोइंग टू बी वेल एंड गुड. ट्राई टू हैव योर कॉफ़ी, राइट? Try to have your coffee, put your alarm, just wake up, right? And get ready and reach to the center on time. Reach on time, this is the most important thing. No need to get late. Every time we will get some messages, sir 2 मिनट रह गया, बाहर रह गए, नहीं हो पाया, एंट्री नहीं हुई, एंजाइटी अटैक हो गया, राइट? सो ऑल दिस थिंग्स आर गोइंग टू हैपन, so please try to reach on time, right? अभी सोने से पहले check your documents, check your docs, right? All your documents, whatever you need to carry tomorrow, you are going to keep it aside, recheck them, है ना? सुबह कुछ भी हम लोगों को जल्दी जल्दी में नहीं करना है, उन सभी चीज़ों को अभी एक बार देख लो। चेक करने के बाद में just wake up and don't skip your breakfast, don't skip the breakfast. This is going to be the very important meal that you are going to have tomorrow. And you can have coffee if you are not having any issues with the palpitation, you can have your coffee along with you. And once you will enter into examination hall, टाइम से पहुंचने के बाद में you will enter into examination hall, you will sit on the chair, right? You will look at your computer screen, right? Make sure when you are sitting you will be getting some amount of time, 15-20 मिनट आपको मिलेगी. Try to do breathing, right? Breathing exercise करनी है. You need to take some deep breathing. This is going to activate your vagus and this will decrease your anxiety, right? When the paper is going to be there, before paper you can adjust your screen. आपकी टेबल सही नहीं है, आपकी कुर्सी ठीक नहीं है, brightness कम ज़्यादा है, you can manage all those things. Go for urination and then before the paper 10 minutes पहले you can go for urination. आपको जो भी जाना है you can come back और फिर वहाँ पर बैठ के 10 मिनट सिर्फ अपन को breathing करना है. You need to tell yourself, you need to remind yourself what good you have done in the past few days. जो भी चीज़ें हमने करी है, हमने सब करना था जो कर लिया था. It's all done and dusted. Now this is the time to fight and we are going to win it, right? तो ऐसा कुछ mindset अपन ने रखना है, खुद को deep breathing करनी है. And then you will be having question number 1 coming. Your paper will start and question number 1 will come. And you will start to have what palpitations again, you will start to have what you know the answer but you are not able to get to the answer, और उससे और एंजाइटी होगी, है ना? आपको आता होगा तो भी ऊपर नीचे होगा, राइट? बट मेक श्योर this is going to be something. Starting के 10 क्वेश्चन you can appreciate, starting के 10 questions you are allowed to change your answer, you are allowed to change your answer because this is going to be a time when you are going to be anxious. आपका sympathetic nervous system ज़्यादा काम कर रहा होगा, you might be anxious. So these are the first 10 questions that you are going to attempt. These are the questions where I'm allowing you to change your answers. Otherwise no need to change answer, don't change your answers. होता उससे कुछ नहीं है बट एक ऐसा रह जाता है कई बार, 1-2 नंबर से अगर कोई रह जाता है तो दे विल बी हैविंग थिंकिंग इन माइंड कि ये मैंने चेंज कर दिया, नहीं तो मेरा सही हो जाता. इट डजंट अफेक्ट बट एटलीस्ट यू नीड टू थिंक इन दिस पर्टिकुलर वे कि मुझे चेंज ही नहीं करना आंसर. वो कौन सा आंसर लगाना है सर? चारों ऑप्शन आ रहे हैं सामने, जो तुमको फेमिलियर लगता है. वॉट एवर इज गोइंग टू बी फेमिलियर, आई टेक अप योर क्वेश्चंस ऑल्सो. वॉट एवर इज गोइंग टू बी फेमिलियर, जो भी आपको फेमिलियर लग रहा है उसको मार्क कर दो. अगर फेमिलियर नहीं लग रहा, ट्राई टू रूल आउट द ऑप्शंस. इट विल इंक्रीज द प्रोबेबिलिटी, इट विल इंक्रीज द प्रोबेबिलिटी कि आपका ये ठीक हो जाएगा, राइट? ओके, सो दिस इज गोइंग टू बी द थिंग. जब क्वेश्चन आएगा तो आंसर भी सामने ही आएगा. यू जस्ट नीड टू रूल आउट 3 ऑप्शंस. आप रूल आउट कर लोगे, यू विल बी डेफिनेटली रीचिंग टू द करेक्ट आंसर. सर ऐसा लग रहा है लगातार 5 क्वेश्चन खराब आ गए, 5 क्वेश्चन आर कंटिन्यूसली, और ये 10 क्वेश्चन बहुत बुरे आ गए और माइंडसेट विल बी चेंज. यू विल बी हैविंग माइंडसेट कि सारा पेपर बिगड़ गया, है ना? बट मेक श्योर सबके पेपर में ऐसे 10-15 क्वेश्चन के सेट आएंगी. तो अगर स्टार्टिंग में डिफिकल्ट क्वेश्चन आ रहे हैं, नो नीड टू वरी. टेल योर सेल्फ कि आगे ईजी क्वेश्चन है, राइट? अगर इजी क्वेश्चन आ गए 10 तो खुश नहीं होना, बोलना है कि आगे डिफिकल्ट क्वेश्चन है, राइट? जो यू हैव टू सॉल्व द पेपर 1 by 1. एवरी अदर क्वेश्चन इज गोइंग टू बी डिफरेंट, है ना? हमको ये सोच के चलना है कि 15 क्वेश्चन अगर स्टार्टिंग में पेपर टफ आ गया, कुछ लोगों का माइंडसेट खराब हो जाता है, एंजाइटी हो जाती है, 10-12 क्वेश्चन गलत हो जाते हैं. तो मेक श्योर यू विल बी इन अ स्टेट कि ठीक है, जैसा भी आया है ये मेरे लिए शायद मुश्किल है, इसके बाद में मेरे लिए आसान पेपर आएगा, राइट? सो दिस इज हाउ यू आर गोइंग टू मेक अ बैलेंस बिटवीन बोथ द थिंग्स कि इजी और डिफिकल्ट के बीच में. अगर फर्स्ट पेपर इजी आ गया, पूरा पेपर इजी हो गया, ज़्यादा खुश नहीं होता, खुश नहीं होना. जस्ट डोंट बी वेरी एक्साइटेड. जस्ट टेल योर सेल्फ कि नेक्स्ट पेपर माइट बी डिफिकल्ट. तो यू हैव टू कीप अ बैलेंस इन बिटवीन. ना तो बहुत ज़्यादा खुश होना है, ना बहुत ज़्यादा दुखी होना है, और ना ही उस पेपर को डिस्कस करना है इन बिटवीन द ब्रेक. वंस यू आर डन in the break you are not going to discuss, do not discuss the paper with anyone. You need not to discuss about anything to anyone. अच्छा हुआ बुरा हुआ, you will be calling your parents. In case if they are along with you, don't tell them what kind of paper you have given, है ना? पता नहीं, बस हो गया, because you are not the one who is going to judge this thing, right? So this is going to be the thing you need to remember. And lastly, when you will enter into the paper 2, you also need to go through the same mindset again. You will be starting from the beginning, right? First say breathing, right? You have to do what? Again, breathing, just like meditation. Just focus on your breath and try to do the paper in single go. Don't mark the options for like later. Just try to go in a single go, do the paper. It is not going to have any kind of negative marking, so this is a point that you are having good for you. That means it is not going to have any kind of negative marking. तो आप जो भी करोगे, जो ठीक लग रहा है वो मार्क कर दो बस, right? This is the ultimate thing we are going to have, right? So with this thing, I think if you are having any doubts, you can ask me, right? So this is going to be the thing you need to remember before going to the examination. My best wishes are always with you. You will definitely pass this particular exam and come back like in a new format for NEET PG. You will come back and we will meet for the NEET PG, right? So this is the thing we are having. You have already done your hard work. You need not to worry about things, right? If you find any difficulties, I can give you my number. Like in the night you are having anxiety or you are not able to sleep, I would be available till tomorrow, right? Till tomorrow after the exam, right? I would be available. I would try to help you out in case if you are having many issues, right? So just try to have the best sleep. Just go now and tell yourself that you whatever you could do, you have already done. जितना होना था वो तो हो गया. अब अपने हाथ में कुछ भी नहीं है. It's up to God, right? And everything is going to be good tomorrow, right? सब अच्छा होगा. ये बोल के एक पॉजिटिव माइंडसेट से दिमाग में ये सोचना ही नहीं है कि क्या होगा छोड़ो, right? Everything will be good. सब अच्छा होगा, right? All right, so I'll take your leave, and tomorrow is going to be the D day, right? So all the very best to each and every one of you. I would like to see you guys on the other side of the fence, right? All right, guys, take care. Now have dinner and sleep well. I'll not take much of time, right? You will all pass. My blessings are always with you. All right.